Very good morning, respected faculties, delegates, and everyone present here. I, on behalf of Association of Metabolic Obesity Physicians and Clinical Endocrinologists, welcome you all to our third national conference, EMOCON version 2. To begin with the first session, may I request Chairperson Dr. Om Prakash Sharma. He needs no introduction. He is consultant physician and diabetologist associated with Techno Global Hospital, Barakpur, to please come on the stage. May I request Dr. Orkojit Ghosh, consultant diabetologist and obesity specialist with BP Poddar Hospital, Kolkata, to please come on the stage. And finally, may I request Dr. Mohua Sikdar Madam, founder and chairman of Dr. Mohua's Chennai Diabetic Clinic, Burdwan, West Bengal, to please come on the dais and start the session by introducing the speakers.
Good morning, everyone. Welcome all of you to this wonderful morning. Today is this first session. Our first speaker is Dr. Shankho Sen. He is MD Medicine gold medalist. He is a physician at Shiliguri Maharaja Agrshan Hospital and Basu's Clinic, Shiliguri. He is Honorable Secretary IMA Shiliguri, West Bengal, Honorary Secretary Clinical Cardio-Diabetic Society of India, West Bengal. He is a EC member of API West Bengal branch, editorial board member of Indian Diabetic Educator Journal of RSSDI. So without much more delay, we'd like to start today's first talk. Dr. Shankho, over to you.
Thank you. Good morning to all of you. It's nice to be back in Kolkata again for this particular program. Thanks Dr. Supratik and team for the invitation. My topic is early onset type 2 diabetes in India, the drivers, the phenotypes and outcome. And I will be speaking on this particular topic, and early onset type 2 diabetes is the important, but we know that when we are discussing type 2 diabetes in the early onset, we have to rule out the type 1 in younger population, particularly the pediatric ones. So type 2 diabetes, once considered an adult disease, is increasingly diagnosed in children and adolescents, closely paralleling the rising childhood obesity rates. And very importantly, obesity and overweight is the leading attributable risk for disability-adjusted life years, particularly in this particular cohort of youth onset type 2 diabetes. It's a distinct and dangerous epidemiology. Early onset type 2 diabetes is a distinct, aggressive phenotype, not merely adult diabetes in a younger body. The rise, the risk, and the gaps will be discussed. With the overlapping incidence and phenotype of early type 2 diabetes, type 1 diabetes and monogenic diabetes are the two entities which should be excluded. So less than 40 years is the definition, and usually living with obesity, but not always. For example, the Asian ethnicities, and here the C-peptide is usually preserved, pancreatic antibodies are negative, and parental history of diabetes is quite common. And diabetic ketoacidosis is very unusual, unlike the type 1 diabetes. So it's often asymptomatic at onset. Acanthosis nigricans is one of the common presenting signs, and when symptomatic, children may present with polyuria, polydipsia, and unexplained weight loss. And cardiometabolic comorbidities are frequently present at diagnosis, like obesity, hypertension, and dyslipidemia. C-peptide levels are typically preserved or elevated at presentation, and pancreatic autoantibodies are usually absent. So these are the key considerations, and when to suspect when autoantibody negative diabetes with strong family history and very importantly dysmorphic features or multi-organ involvement are the one which are non-type 2 diabetic patients, we should rule out these things before we are stereotyping them as type 2 diabetes or the early onset. So screening should begin at age more than 10 years or at the onset of puberty, whichever occurs earlier in these patients where we suspect. And the drivers of youth onset type 2 diabetes are many, and obesity is most important among these. So early onset diabetes is no longer an anomaly. It affects around 17.2% of young adults under 40. It's a huge number. And it's an unique clinical profile, and yet they exhibit higher insulin resistance and worse glycemic and lipid metrics than their obese counterparts, the non-obese ones also. And microvascular complications also hit 15 to 20 years earlier than late onset diabetes. So SGLT2 inhibitors and early lifestyle interventions are quite critical for shifting this trajectory. And the sedentary behaviors driven by modern transport and increase in screen time are accelerating the muscle mass loss and visceral fat accumulation, triggering the underlying beta cell insufficiency. So despite appearing lean externally, these individuals suffer from extreme glucotoxicity, lipotoxicity, and highly insulin-resistant internal environment. And the ectopic fat and insulin resistance are the true primary drivers of premature cardiovascular metabolic risk in India particularly. And counterintuitively, the non-obese early onset diabetes patients demonstrate significantly higher fasting and postprandial glycemia, higher triglycerides, and higher insulin resistance than the obese counterparts. And they are having genetically loaded metabolic dysfunction, which require early intervention. And they have worse glycemic control and atherogenic lipid profiles, setting the stage for accelerated vascular damage. So they are at more risk compared to the late onset ones. So retinopathy, peripheral neuropathy, and nephropathy, the microvascular threats loom much earlier compared to the late onset diabetes. And the microvascular destruction in 35-year-old early onset diabetes patient perfectly mirrors that of a 48-year-old late onset diabetes patients. So this glucolipotoxicity is a toxic combination where strips away nearly 2 decades of microvascular health compared to traditional late onset timelines. So the paradigm shift in diabetes is very important, and the premature microvascular failure, which is 15 to 20 years ahead of schedule, is something we should be worried about. And very importantly, the physical inactivity and social friction prompting ectopic visceral fat and thin fat insulin resistance, all are cardinal features of this particular type of diabetes. So the aggressive phenotype is more aggressive. Puberty itself creates a critical window of marked insulin resistance, placing maximum demand on the pancreas. And all these modifiable and non-modifiable risk factors are associated with type 2 diabetes of early onset. So obesity is the strongest modifiable risk factor, and we should focus on this. And central and visceral obesity confer the higher metabolic risk than BMI alone, particularly in non-Caucasian populations who develop complications even at lower BMI thresholds. So the age gradient is important. Sex differences are there. Usually globally, boys have higher obesity prevalence than girls across most age groups. But in Indian context, the urban Indian boys show higher childhood obesity, but girls demonstrated higher insulin resistance and metabolic risk, especially after their menarche. So in early childhood, obesity is very important because obesity predicts adolescent obesity and future risk of type 2 diabetes. So there are multi-level risk factors for youth onset type 2 diabetes, and diabetes is very much related to the environment, the socioeconomic status, the sedentary behavior, the processed foods, the lack of exercise, inadequate sleep, and very importantly, the genetic predisposition is in the background. So epigenetics of early life programming, maternal factors also are important, and very importantly, the birth weight paradox is there. Both fetal undernutrition, small for gestational age, and high birth weight are linked to a higher risk of developing obesity and metabolic syndrome in later life. And intrauterine exposure to maternal hyperglycemia is a major modifiable risk factor for development of type 2 diabetes in the offspring in early age. So the determinants of progression to type 2 diabetes depends on an obesogenic environment and simultaneously the genetic predisposition and epigenetic changes. So the physiological resistance, which is puberty, is naturally associated with a transient state of physiological insulin resistance driven by a surge in growth hormone secretion. And with this shift is normal, the increasing weight during the pubertal transition likely augments this resistance and tips the balance towards frank diabetes at risk of youth. Very importantly, this physiological vulnerability explains why the average age of onset for pediatric type 2 diabetes is around 13 years. So the adolescent peak is important and the role of puberty with surge of growth hormones is important. There are subgroups of patients with type 2 diabetes which reveal insulin deficiency as a major driver. So insulin deficiency is identified as a major driver of type 2 diabetes in young Indians. So it's not only insulin resistance, but compared to the Caucasians, Indians have insulin deficiency at an earlier age. And the beta cell dysfunction is related to the genetic susceptibility, faster beta cell dysfunction and decline, and the glucotoxicity and lipotoxicity which comes together. And this extreme metabolic burden on beta cells predispose them to failure. So there are various mechanisms underlying pathophysiology of type 2 diabetes in children with obesity. And very importantly, we are discussing this because the complications occur much earlier and they are quite aggressive. And the microvascular complications and macrovascular complications occur quite early, and significant comorbidities are associated with type 2 diabetes in childhood like MASLD, OSA, PCOS, and diabetic dyslipidemia. So rapid beta cell decline, high microvascular burden, high complication rates, and earlier complication, and earlier than type 1 diabetes mellitus even is very important, and it occurs more rapidly in youth onset type 2 diabetes compared to type 1 diabetes. So early macrovascular and cardiovascular risk is very important with rapid rise of hypertension, atherogenic dyslipidemia, and subclinical vascular damage. So these are the metabolic syndrome is associated in early age because those are the risk factors as well as aftermath of this early onset type 2 diabetes. And the psychosocial impact and life expectancy is definitely hampered with these particular early onset diseases with reduced life expectancy, psychological burden, disordered eating and stigma, and adherence challenges are quite important. So regarding my last part of my talk, regarding the management challenges, lifestyle modification is definitely the cornerstone, but it's very challenging. The dietary modification, physical activity, and behavioral changes are paramount. But most importantly, the behavioral structure with weight, glucose, diet, activity, family-based approach, very importantly, the family needs to be engaged, and the poor long-term adherence, 60% of adolescents disengage from the care within 7 months, and low perceived urgency, like we do in type 1 diabetes, we show much more urgency. Youth with type 2 diabetes often lack the immediate symptoms, so they lack motivation and they need more follow-up for sustained self-care. So regarding pharmacotherapy, as I mentioned, the first after lifestyle modification comes metformin, which is the mainstay. It reduces the hepatic glucose production and improves the peripheral insulin sensitivity. And nowadays, GLP-1 receptor agonists are available to us in affordable costs. So, but we have been very less frequent in using these molecules, but now we have better chances of providing these advantages to our patients. So why it is hard to treat? Because there is rapid beta cell loss. The socioeconomic burden from an earlier age is quite important, and high treatment failure with metformin monotherapy is there. And the accelerated disease biology, as I discussed, is something we should take care. So it is having a multi-system assault on most of the organs in the body, and particularly for kidney disease, there are 4 to 5-fold increase in the risk of kidney failure, in particularly with early onset type 2 diabetes compared to the late onset ones. So we need a quite different approach for treating early onset type 2 diabetes, and the key considerations will be discussed in my next few slides. Current ICMR guidelines recommend screening at the age of 30, because as I said, there is 15 to 20-year acceleration in universal morbidity and high prevalence, and we should not wait for visible obesity to be treated aggressively. So generic exercise more advice fails due to unique social and energetic barriers in our community, and lifestyle is insufficient. We have to start treatment. There is even might be need for metabolic bariatric surgery also in those who are not adhering to treatment and cannot control their obesity. So the central of obesity, intensive weight loss approaches, pharmacotherapy, and metabolic surgery are the targets for achieving early weight loss. So prevention is very important. Beyond caloric restriction, the sleep should be improved, mental health should be enough, and magnesium, vitamin D, A, all should be replaced. So failure of monotherapy is there, and so along with metformin, some who are having early beta cell failure needs insulin. Now, in the new era of GLP-1 receptor agonists, it is recommended as the second line after metformin. Liraglutide has been there with us since long. Now we have multiple newer molecules in our armamentarium to fight not only obesity but also diabetes. And SGLT2 inhibitors primarily have the advantages of renoprotection, and that is quite important. So to break the loop, the impact of SGLT2 inhibitor is very important. With weight loss, internal cardiovascular risk reduction is quite there, and SGLT2 effectively targets the specific glucotoxicity driving the end organ damage. Then reproductive health in women in early onset type 2 diabetes is another huge topic, can be discussed in another session. To summarize my talk, that is 17.2% prevalence of early onset diabetes is there, it has been found in India, and 60% of non-obese thin fat phenotype with worse insulin resistance and glycemia. The drivers are severe inactivity, sedentary life strips the muscles, loads the visceral fat, and the complications, as I mentioned, 90% complications hit 15 to 20 years early, and with retinopathy of around 27%, nephropathy 33%, neuropathy 43%. These are huge numbers. Lifestyle, barrier-specific, energy, time, care interventions are quite important. Management is challenging due to limited pediatric therapies, poor lifestyle adherence, and significant psychosocial barriers. And early obesity-focused life course intervention, multidisciplinary care are essential to alter the long-term outcomes. And the existing models of prevention care, largely designed for older adults, are inadequate for addressing the unique metabolic, psychosocial, and lifestyle needs for the younger individuals. And reversing the trajectory of early onset type 2 diabetes and improving outcomes for this group at high risk will require coordinated transsectoral actions spanning healthcare, education, policy, and community systems. I thank you all for your patient hearing. And this is my hospital, and on winters we have this view from our hospital of the mighty Kanchenjunga. And this time, on the 6th and 7th of June 2026, we invite you all to Siliguri for the 5th annual conference of CCDSI. The CCDSI con will be held on 6th and 7th of June 2026. You are welcome to join us in Siliguri. Thank you.
Brilliant presentation, Dr. Shankho. We'd like to ask a few questions from the audience if you have any. Okay, by the time they ask, I have a question for you. For the pediatric diabetic group, do you prefer GLP-1 analog?
See, the GLP-1 analogs, there are certain recommendations with certain incretin mimetics that even after 12 years of age you can use. But the current ones which you are using, the semaglutide, they have till now on-label, it's off-label use, but 18 years is the target. But in pediatric usage, like with liraglutide, there are studies and there are recommendations it can be used above 12 years of age.
Okay. So, any of you?
Well, sir, thank you for the nice presentation. You have already told that sometimes this lifestyle modification is not all. But before going to this pharmacotherapy, what advice do you want to give to these people regarding lifestyle modification?
The general advice for lifestyle modification, like dietary restrictions with a good dietitian's advice, and mainly the physical exercise, the sedentary.
Physical exercise, because the guidelines are there for adult people. But do you specifically follow something for these, say, pediatric or, say, young diabetic groups, some specific guidelines for physical activity? Because most of the people are sedentary, definitely.
No, there is the recommendation, no, that at least 5 days a week, 30 minutes. This is for the adults ones you are mentioning. But for the children, or particularly in the pediatric age group, or between 12 to 18, this age group, we should always promote more activities like games, outdoor exercises, and so on.
Shouldn't we come with some specific guidelines for these people?
I am not aware, sir.
Okay.
Well, the semaglutide is available. It's indicated.
Yes.
Semaglutide.
Yes.
If it is indicated whether injectable or oral.
No, it's not like that. Semaglutide is one of the molecules in our armamentarium to not only control obesity but also type 2 diabetes. And there are specific indications. That's for everyone. Semaglutide is both an anti-diabetic medication and an anti-obesity medication. The oral and injectable are options. You can pick and choose as per your patient's requirement.
Thank you, Shankhoda. Just one addition what you had mentioned regarding that adolescent guideline. there is one very beautiful guideline that had been laid down by Dr. Anup Misra et al., most probably in the 2014. And when the first time we know that the abdominal circumference need to be given emphasized to define obesity. And that guideline you will get beautiful lifestyle recommendation.
Can you summarize a bit what is going to answer this question?
Is whatever we are telling 30 minutes, 5 days for adult, it is 1 hour every day. And the screen time is also mentioned there. It should not be more than 1 hour. So apart from that, there are specific customized dietary restriction plan for the adolescent group and the pediatric group.
Thank you, Sham.
Okay.
I think I
Last
will
one.
add the answer regarding the use of GLP-1 in the adolescent groups. I think the semaglutide has been there from the age group of 12 to 18, not the tirzepatide. So this is the on level, not the off level. So you can use the semaglutide in your clinical practice from the age group of 12 to 18 for the obesity as well as if it is type 2 diabetes. Thank you.
Okay. So thank you so much. We would like to ask our next speaker.
I would like to invite our next speaker is Dr. Shambhu Shamrat Samajdar. Yes, he is MBBS MD DM Clinical Pharmacology Gold Medal and PGDP in Indo Diabetes RCQ UK, Fellowship in Respiratory and Critical Care WSA, and he has lots of publications also, and he has got some awards also. So I think, Shambhuda, I think you should start, okay?
Thank you, sir. Thank you, Chairperson, and thank you, Dr. Supratik Bhattacharya, for giving me this opportunity. Actually, for next 15 minutes, we'll try to understand why one number can mislead diagnosis and monitoring. And for this particular session, I shall refer to a recently published article from us in Lancet regional edition of Southeast Asia. So all the informations you will get also in this freely downloadable paper. So we need to acknowledge India is uniquely high burden of HbA1c distorting physiology, or biology rather we can say. If you talk about the prevalence of anemia in India, it is around 50 to 60%, and sometimes in elderly population, it reaches 70%. And hemoglobinopathies, they are also very much important, especially geographically clustered in different parts of India, especially Madhya Pradesh, Chhattisgarh, Maharashtra. There is a very good number of studies, even the trivial population are suffering from it. If we talk about G6PD deficiency, again, a hidden source of underestimation. The prevalence is around 7 to 9% sometimes, and higher prevalence in tribal group. And why it is important, we'll talk because it shortens the red cells lifespan, and therefore there would be a lower HbA1c despite higher glucose level. Apart from that, there are studies which suggest the lab system adds another layer of uncertainty. There was one study which suggests 75% of labs used HbA1c for diagnosis, but only 70% of those assays were NGSP certified. And another study had shown that 87% of this HbA1c testing, they were not appropriately standardized due to certain faulty analytical performance. So we need to acknowledge biological variability in patient and analytical variability in the laboratory. So why it is not always that HbA1c reports suggestive what is the glycemic status in one particular patient? Because we know that HbA1c generally reflects glycation plus red cell biology, not glucose alone. And if we talk about it as HbA1c as a composite biomarker, then the glucose exposure plus RBC biology, that ultimately need to be understood, and that is why if there is something happened in that RBC biology that will result in discordance in the HbA1c report. And there are certain terminologies like HbA1c, glucose index, glycemic index, and glycemic gap. Whatever we are measuring HbA1c and whatever is actually predicted HbA1c, if we can do through the glycemic status from the glucose level from the body, then it will show the difference. So same patient, same mean glucose, but HbA1c can be different. So there are multiple studies. We had done this scrutiny of different studies, and we had found few important studies from these South Asian populations. Most of them are from India, one study from Pakistan, and one study from Bangladesh. If we want to understand the take-home message from this group of studies, I had highlighted these 3 high-impact take-home message. Because of this paucity of time, we can't go in details of those studies. But first, the HbA1c may miss pre-diabetes. In one South Indian cohort, what we found that OGTT identified 88% pre-diabetes case, whereas by HbA1c it was only 45%. So HbA1c alone can miss a large proportion of dysglycemia. Next, another important issue is that HbA1c cutoffs. And if we talk about the ADA cutoff of around 5.7% or IEC of 6% for pre-diabetes, that can miss around 38 to 64% of pre-diabetes cases. And this is from one very good methodology study from Chandigarh. So again, for pre-diabetes, global thresholds may underdiagnose Indian populations. Another important fact is that HbA1c may also overestimate dysglycemia, especially when there is anemia. So there is one Pune cohort where they had shown HbA1c detected 23.3% pre-diabetes, but with OGTT it was 7.8%. So we can see positive predictive value for HbA1c dropped to 7% in anemic individuals, and we know all that iron deficiency and different hematological factors can falsely elevate HbA1c. We'll try to understand few important pitfalls like iron deficiency anemia. We know how this altered erythrocyte turnover changes in RBC lifespan and population dynamics. Therefore, there will be more older circulating RBCs, and therefore there will be more time for glycation, and ultimately it will lead to falsely elevated HbA1c. So we'll overdiagnose pre-diabetes and diabetes, and this mislead the assessment of glycemic control too. Another important part is the hemoglobinopathies. Again, we had seen different hemoglobinopathies are common in our country. There are different variants of hemoglobins, and that changes the glycation behavior and measurement. So ultimately the RBC lifespan will be shortened, less time for glycation, and falsely low HbA1c despite hyperglycemia. So if glucose is high but HbA1c is low, we need to think about hemoglobinopathy. Another important factor is the G6PD deficiency, and we had shown that the prevalence is between 7 to 9% in India. So if you talk about this G6PD deficiency, which is a hidden disruptor, we can say, what happens biologically, that due to enzymatic defect, there will be more vulnerability towards the oxidative stress. So RBC is prone to subtle ongoing hemolysis, shortened RBC lifespan, less time for hemoglobin glycation. So it will lead to falsely low HbA1c. And there was a landmark paper published in Diabetes Care in 2025, which had suggested if there is clinically significant G6PD variants, so that will falsely reduce the HbA1c by around 0.9%. And there would be a possibility of 4-year delay in diabetes diagnosis, more chance of microvascular complications, and that chance increased by 37%. So these are different other factors which may influence HbA1c value, and we need to also consider, as we were mentioning, the laboratory pitfall, the assay standardization in India. Not all HbA1c measurements are equal. We know because the results may vary from HPLC to immunoassay to enzymatic methods. So same patient, different lab may give you different HbA1c value. So we know that HPLC that can also be affected by different hemoglobin variants and leading to erroneous values, abnormal chromatograms. So what to do when HbA1c does not fit the story? First of all, we need to confirm the diagnosis, and for that, we need to compare HbA1c with fasting, post-meal glucose, and SMBG. We need to look for those discordants. Then we need to understand, we need to evaluate the basic hematology, and here we must say the RDW is a very important clue for different red cell disorders. We know these scenarios. If both the RDW and HbA1c elevated, we need to think about iron deficiency, so that will lead to falsely high HbA1c value. Similarly, if RDW is more normal or low HbA1c with high glucose value, high fasting or PP value, we need to think about hemolysis, G6PD or other HB variants. Now, if discordance persist, we need to assess for the iron status, reticulocyte count, identify the altered RBC turnover, and look deeper if needed. We need to do sometimes the hemoglobinopathy screening and G6PD deficiency testing. So we need to use the right glycemic tool. OGTT, we know the gold standard in case of discordance. Apart from that, we can use other methods. So beyond HbA1c, if we talk about smarter glycemic assessment, we need to acknowledge, yes, HbA1c is useful, but not sufficient for every patient. We need to move toward a multi-parametric approach. And therefore, the OGTT gold standard when HbA1c is discordant, and it can detect early dysglycemia missed by HbA1c. So for day-to-day monitoring, SMBG could be helpful, and for comprehensive glycemic profile, sometimes we need to do a CGM because it can capture the variability and trends, not just those averages. And these alternative biomarkers also we know, the fructosamine, short-term glycemia, it gives us a message of 2 to 3 weeks, then glycated albumin, especially it is important for anemia or CKD, but we need to interpret cautiously when certain albumin metabolism become abnormal. And this 1,5-anhydroglucitol, which is very important, especially it can reflect those postprandial spikes, but less reliable in CKD or persistent glucosuria. So very important, again we need to reiterate that right test in right patient and right setting can give us a better glycemic assessment. And for that, if we talk about a risk stratified approach, India focused, for low resource setting, we can use this practical scalable approach like SMBG. We can do this basic hematology and then selective OGTT when diagnosis is uncertain, certain HbA1c glucose discordance present, because we need to focus on affordability, accessibility, and early detection. But at the same time, when we have higher resource settings, then we can talk about this precision-driven approach, CGM, comprehensive hematological workup, selective alternative biomarkers, because we want to focus on accuracy, personalization, and advanced monitoring. Again, we had given this table in our paper that how should we approach for low resource setting and middle or high resource setting. So we need to acknowledge again and again, one size fits all HbA1c need to be considered towards a risk stratified, context specific approach. So HbA1c is useful, no doubt in that, but not infallible. In India, anemia, hemoglobinopathies, G6PD deficiency, and assay variability really matters. OGTT remains critical for diagnosis when discordance is suspected. Monitoring should integrate glucose data, not only the HbA1c. And we need to think about hematology when the number does not fit the patient. So don't ask only what is the HbA1c, please ask, can I trust this HbA1c in this patient? Thank you very much.
Excellent talk by Dr. Shambhu Shamrat. Is any question from audience? Yes.
Thank you, Shambhu, for a wonderful, you have very nicely elucidated the limitations of A1C. I'll just add one more, very common in our country, the use of Dapsone in Hansen's. These patients of Hansen is very common disease, and Dapsone can lead to falsely low A1C. So that one should always remember.
Absolutely, sir. And there are other factors also. During this study also we had seen that if you do HbA1c in the monsoon season, there will be falsely elevation in the HbA1c, whereas in the winter season, the HbA1c will be falsely low down. So seasonal variability is also there in the HbA1c. So there are different other factors. I think we had one slide on that too.
Dr. Shambhu, I just want to make a comment, like in spite of all the pitfalls about HbA1c, whatever we have, still HbA1c has got the, like we have most of our trust on HbA1c, because when patient comes to us, like suppose for last 3 months, first 2 months they are in not a very good control, they are doing all sort of irregularities, but when they are coming to visit us, immediate 20-25 days they will be in regular habits, diet restrictions and exercise, everything will be done. So when we do the HbA1c, we can straight away see the difference, like the fasting PP will be very less, whereas the HbA1c will be very high. So in that way we can, I'm sure our senior sirs also will be, they have also the same experience like me as well. Like with the HbA1c we have like...
True, madam. So actually, but at the same time, we need to reiterate the problem with HbA1c. There could be falsely elevation of the HbA1c. So before blaming the patient for the lifestyle, we need to consider, we need to think about other pathology that could be influencing that HbA1c value.
No, my point is many of the time they themselves will, if you ask the patient properly, they will tell, okay ma'am, we have not in very good shape in first 2 months.
That's okay. That's okay. We are not telling that HbA1c need to be abundant, but we need to be specific, we need to be personalized, and when there is issues, we need to consider other factors. We need to consider hematology when interpreting HbA1c.
Dr. Shambhu, iron deficiency anemia is very common, especially in our country. So what will be the impact of iron deficiency, particularly on the HbA1c?
Yeah, so as we had mentioned that iron deficiency anemia can be resulting into distorted HbA1c.
And also, I think we have to mention about the assay variations also with HbA1c, and also the use of kits sometimes which is not always reliable. So thank you, Shambhu, for the wonderful presentation. Can we move on to our next speaker? Can I invite on stage Dr. Kaushik Saha, who is MD, DCH, MRCP, FRCP, Director of ADEA Diabetes Care Center, and Professor and HOD KPC Medical College. I think he's going to talk about hypoglycemia and its considerations. Thank you. You can present your slides.
Good morning, everyone. I think in the morning, I will say regarding the hypoglycemia. So, opposite to the original state now at present moment, because everyone has got the breakfast. Now I am talking about the hypoglycemia, risk stratifications in the Indian setting. So, my topic has been changed into Indian settings. Now, my presentation will be on 10 different areas. If I divide into my topic into 10 areas, first I will describe about the Indians' diabetes landscape. Then we will talking about the hypoglycemia classification. Then I will talk about the risk stratification framework. Then number 4 will be the drug-specific risk profile. Then I will talk about the CKD. Then I will talk about the monitoring and awareness, clinical consequences, prevention and management, and some special situations and takeaway. So these are the 10 different slides. So first I will talk about the India's diabetes landscape. I think everyone knows about all these things, so I am not spent any time here because India is a capital of diabetes, so more than 101 millions. And I think if you see the projection in 2031, it will cross 172. So everyone has to be known regarding the diabetic portions and something like that. And regarding the states, I think although the Goa and Kerala has got the highest populations of the diabetic patients, but still West Bengal is not far behind. And I think so regarding the discussion of the hypoglycemia, I think the more important regarding the type 2 diabetes. Now coming to the classifications. I think why we are talking about the hypoglycemia in the settings of type 2 diabetes, because nowadays we have a lot of drugs which causes a different amount of HbA1c reductions, but still hypoglycemia is more dangerous than the hyperglycemia. You can see that 1.76% of CB mortality has been increased with each each episodes of hypoglycemia. And in our country, only, I think Shambhu has already said regarding the HbA1c, but the importance of CGM is not there because of the cost, so less than 5% actually has got the CGM. And you can see the drug profile, in spite of all the drugs like GLP-1, SGL2, something like that, you can see that 30% are on glimepiride and the patient is on the insulin around 18%. So around more than 50% patients are on the drug which causes the hypoglycemia in spite of having all the solutions in our hand. So classification, I think everyone knows. I am not spending more times. I think the level 1 is around 70, level 2 is around 54, and level 3 around severe hypoglycemia where there is no glucose burden. I think this is the only things we have to know, the level 1, level 2, and level 3. Now coming to my third part, that is the risk stratifications. I think everyone knows everything about the hypoglycemia stratification, but still we ultimately not follow in our clinical practice regarding the risk stratifications. I think the 6 important areas are most common. Whether the patient is on the insulin or sulfonylurea. Number 2, that exercise-related glucose utilization, that has to be assessed. Number 3, the renal failure, that means the kidney status, that has to be assessed. 4, missed meal, that is the fasting, or the cultural areas like the Ramadan. So that has to be, again, consideration regarding the treatment. Number 5 is the alcohol-induced suppression, that is very important in our country. And number 6 is the improved control. When we have got the more HbA1c reductions, we don't reduce the dose as far as the possible is concerned, and patient may go into the hypoglycemic state. So these 6 things has to be remembered in your clinical practice whenever you practice as a diabetologist or endocrinologist. Another important risk factors, I think the history of severe hypoglycemia, that is very important whenever you prescribe something like that. Number 2 is that hypoglycemia unawareness. I think this is a typical area. Patient is having the hypoglycemia, but patient does not have any symptoms. So in that case, I think you have to change your treatment protocols. I think in my next few slides, how to tackle this hypoglycemia unawareness, I will say definitely. And that is important things, because if you are not controlling this hypoglycemic unawareness, I think you have to have going into the severe, that is a level 3 hypoglycemia in the patients who are actually having, you can prevent to go into the level 3 hypoglycemia. Another important thing is the type 1 ladder. I think very important. There is a huge fluctuation of the glucose. Sometimes there will be 350, 400, sometimes it will be less than 50. So you have to have a modification modules to structuring the drugs in this group of the patients, and that is very important. And don't forget the importance of classical diabetic, autonomic neuropathy, and the HbA1c, that means the false lowering of the HbA1c in certain situations. So all these things has to be there in your clinical practice to assess everything. So, as I have said that hypoglycemic unawareness is very important things. In that case, probably less than 50 will be having the cognitive appearance and something like that. You have to change, and all these things, vicious cycles are there whenever you have got the hypoglycemic changes and something like that. And here the CGM has got a definite role to find out if the time below range is less than 70, is less than around this 4% or more than 4%, then probably we have got the level 1. If the 54 levels is more than 1%, we have got the level 2. So in that case, you can stratify that the patient may go into the hypoglycemic areas and like that. So ADA has got the hypoglycemic risk stratification, tier 1, at risk, patient receiving insulin, sulfonylurea or meglitide, then probably they have a tier 1 risk. Tier 2 that, if you have got the higher risk, that is tier 1, plus any of the major risk factors or the other risk factors. Major risk factors, I think, the history of level 2, level 3, hypoglycemia unawareness, eGFR less than 45, cognitive impairment, or the long-standing type 1 diabetes. So it may have the tier 2 hypoglycemic risk. So according to that, you have to modify the drug schedules in your clinical practice. Now there are drug specific, I think everyone knows that the glimepiride and insulin has got the highest amount of hypoglycemic risk. So you have to avoid all these things in your clinical practice. For fifth is the CKD. I think if there is a emerging of the CKD, I think you have to reduce the dose. I think you know that why in CKD you reduce the dose, because there is a renal insulin clearance, less amount of renal gluconeogenesis, and all these factors ultimately play, and that's why you have to reduce the dose of any drugs in case of CKD, and don't forget of all these things. So if the eGFR is less than 30, I think you have to stop all the sulfonylurea, stop the metformin. Insulin is a very low dose, and the DPP-4 inhibitors, if the sitagliptin has been used, then probably 30. If the linagliptin, you can use the full dose, and the specialist referral and the dialysis. So you have to know that patient is actually going into the nephropathy or not, and according to that, you have to adjust the dose. Now coming to the monitoring and awareness. I think the monitoring and awareness is very important, because 25 to 30% of type 1 diabetes develops the hypoglycemic unawareness after the 10 years. This is a very, very important data you have. So every patient is a potential candidate of hypoglycemic unawareness, and according to that, you have to act. I think there are a lot of screening methods. I am not going into the details because only 15 minutes is allocated for me. So it's very difficult to say everything regarding the 15 minutes, but there are some screening methods like the gold scores, Edinburgh scores, and something like that. So you can use all these scores in your clinical practice. So these are the list of the tools you can use in your clinical practice, but still the clinical areas, judgment, history taking, and the drugs which are using is the most important as far as the hypoglycemia is concerned. Now coming to the clinical consequences, because why we are talking about the hypoglycemia in a conference of type 2 diabetes, whether we should talk about the hyperglycemia. Why we are talking about the hypoglycemia? Because there are cardiovascular consequences like the QTc prolongations, coronary vasospasms, platelet activations, inflammatory surge, arrhythmia risk, symptomatically adrenal surge. So there are a lot of complications, cardiovascular complications. So hypoglycemia has to be prevented by any cost in your clinical practice. Regarding the neurological, I think you can see the focal neurological deficits, seizures, transient global amnesia, cognitive decline. So a lot of list regarding the neurological complications. So that has to be seen in your clinical practice. So I think the prevention and management of hypoglycemia is very important. How do you do this? As I have said earlier, the history, hypoglycemic history review, hypoglycemic unawareness has to be screened, medication review, what are the medications you are on, then the patient education, so how to tackle the hypoglycemia, and the glucagon prescriptions. I think it is not possible in our country because of the cost and because of the very short shelf life. CGM initiations, I think it is in the way to have the CGM in everybody if the price is going down, dietary counseling, so everything has to be done regarding the prevention and awareness. And that has to be done in your clinical practice without any hesitations, because the hypoglycemia is more dangerous than the hyperglycemia. That things has to be remembered by every clinicians. Now regarding the acute management, I am not going into the details of hypoglycemia because everything known by everyone. There is a level 1, level 2, level 3. How do you tackle? I think everyone knows. So I am going into the special populations. This is my 9th part of my discussion. There is a special populations. So you can see that the individual glycemic targets are different. So everyone should not have the same glycemic target as you have seen. For example, the young individuals, the HbA1c may be less than 6.5, but you have got the elderly, where maybe the 8.5 will be the highest one. So according to that, you have to stratify the HbA1c target so that you can prevent the hypoglycemia in that individuals. If you go on strict individualized like the 6.1, 6.5 in cases of elderly patient, I think in near future you have got the hypoglycemic episode. So that's why you have to change the HbA1c goal so that you can have the less incidence of hypoglycemia. Now, according to that, you have to have healthy, complex, intermediate, and very complex. So it is an individualized approach. That is actually required in everywhere. Otherwise, you cannot prevent the hypoglycemia in your clinical context. And you can have a special population like the pregnancy and GDM or pre-existing GDM where there is a very strict control of hyperglycemia. Probably the fasting around 90 to 100, PP is around 120 to 300, 130, and in that situation there will be chances of hypoglycemia. So you have to prepare to speak something regarding the prevention of hypoglycemia in this group of the patient. And also in the fasting like Ramadan and the religious fasting, there will be very, very difficult to control the glycemic status, hypo and hyper in different parts of the day, and you have to have a very careful approach in these areas. And also in the lean individuals, type 2 diabetes, there is a very difficult to control the glycemic status, as well as the post-bariatric hypoglycemia, where it is very difficult to control the glycemic status because of different absorption protocols and something like that. So these are the special population where you have to have adjustment of different drugs, different approaches to reduce the chances of hypoglycemia. So newer agents may be helpful in these areas where there is a less chances of hypoglycemia, less incidence of insulin secretion as far as the patient is concerned, and probably in this group of the patients we may use the SGLT inhibitors and DPP-4 inhibitors and the GLP-1 more as compared to the insulins as well as the glimepiride like that. So insulin profile has to be changed because the basal insulin has got the less chances of hypoglycemia. So preferably we should use the basal insulin first, then you can use the prandial insulin. So in that way, the master hypoglycemia risk assessment is like that. The medication, renal function, hypoglycemic unawareness, prior hypoglycemia, cognitive status, age, food security, and the monitoring, alcohol, total risk score. So everything has to be assessed before prescribing any drug in your clinical practice so that you can reduce the chances of the... I will take 1 more minute. So we can have a software for this. You can individualize this software. Everything can be put into the software, the risk factors, and then you just check whether this patient will require the monitoring of hypoglycemia or not on a frequent basis by doing this software. So this is my last slide. There is a takeaway. So India is not just battling the diabetes. We are in its very epicenter. The science is clear. The urgency is not. And that's where we are falling. So we don't go fast to control the blood sugar level. CKT does not complicate the diabetes. It quietly determines the outcome. So it has to be remembered in your clinical practice. Hypoglycemia is not a side effect. It's a preventable worrying we ignore. Less than 5% use this CGM. This is not a gap in technology, but a gap in access. And the future is not about the treating the diabetes, it's about the predicting and preventing it. So that's the thing we have to know whenever we treat the diabetes in your clinical practice. Thank you.
Well, thank you so much and very good, brilliant presentation. We will now move on to our next speaker, Dr. Mridul.
No
the
questions?
question we will be asking later at the end of the session. So Dr. Mridul Bera is a consultant physician at Narayana Super Specialty Hospital. He is a consultant physician and critical care expert at Indus NH. He is a fellow of IDF. He has got multiple presentations. He has published 2 books in the field of diabetology. So over to you, Dr. Mridul Bera.
Okay. Good morning, all of you. And before I start, I definitely thank the organizers for giving me the opportunity to talk here. My subject is a little bit different. I think I'll be talking on the diabetes distress, that is the first practice guidelines and integrated care. I think talking about the diabetes distress, it is one of the most neglected part of the diabetic management. So in the next 15 minutes, I try to bridge the gap between the glycemic control and the emotional well-being. So how we can define the diabetes distress? I think it is an emotional burden. First of all, you have to think about it. So by definition, you can say an emotional response to the relentless daily challenges of living with and the managing the diabetes. So etiology arises from the fear of complication, social stigma, and perceived inadequacy in the self-care tasks. Symptoms always related to the diabetes characterized by the feeling of being overwhelmed, feeling of frustration, discouraged especially regarding the diabetes. An impact. It has an impact not only on the glycemic control, but also of the medication adherence and self-care behavior. So it is important. That's why in the ADA 2024, in the standard of care, they have mentioned it, the mandatory routine screening for diabetes-related mood concerns and stress and quality of life. Now, what is the difference between this diabetic distress and the depressions? I think the critical difference is coming for this, the word, that is the diabetic distress. Particularly, if you have the diabetic distress, always you have this coming from the diabetes management challenges and the burden. On the other hand, if you have the major depression, it is more generalized, not necessarily tied to diabetes. And diabetic distress have the frustration, anger, burnout, all is coming from the diabetes demands. Now, in the major depression, it is more generalized. The patient is having sadness, anhedonia, hopefulness, and all these things. And if you go for the context specific for the diabetes distress, that means the diabetes is exhausting. And in the major depression, the life is exhausting. And the primary treatment for diabetes distress is not about you can say the antidepressive part, but also we have the diabetic specific education, problem solving, and the peer support. But in the major depression, you can use this clinical psychotherapy and the drugs. Now, the thing is the diabetes distress and the major depression can coexist. And even if the patient is having severe diabetes distress, it can lead to the major depression. Now, how we understand this diabetes distress? I think the 4 domains is very important. As the diabetic distress is having a huge amount of emotional burden, the main thing is that this is coming from the emotional burden. I am so angry that diabetes controls my entire life. It can come from the regimen distress because I cannot keep up with the injection. It is just too much. And also not the injection, but also the number of medicine the patient has to take. It can come from the interpersonal. My family does not get it, and it makes me feel alone. So loneliness will be there, coming from the family, coming from the friend also. And the physicians have also been responsible for giving the patient the diabetic distress. My doctor tells me to do better, but never asks how hard it is. Now, if you think about the prevalence of the diabetic distress, in the global prevalence is 36%. And if you can go to the South Asian, it is around above the par. That is 44% people is suffering from diabetic distress in the South Asia. In the Indian context, it is about 42%. And always we have you can say the South Asian face unique social cultural stressors that exacerbate the emotional burden of diabetes. Talking about the Indian scenario, I have already said about this. It is about the 42% people of the diabetic patient in India suffering from diabetes districts. It has some regional disparities, and because of the cultural things and all the socioeconomic factors, in Punjab it has got 18% and also the 61% in Chennai. And always the urban patients suffer the more diabetes districts compared to the rural population. Now, what is the neurobiological mechanism? How it has an effect on the diabetes, you can say the glucose regulations. Now, if you have the chronic diabetes stress or the diabetes distress, it will definitely activate the HP axis and the sympathetic nervous system. It will elevate the cortisol and the catecholamines. That will go on to give you the insulin resistance and the glycemic variability. So we have got this glycemia has been there. And you can have the vicious cycle. If the patient is having diabetes distress, it will definitely go on to give you the altered glycemic metabolism, and also the patient may have the higher glycemic variability leading to the more and more distress. So it is a vicious cycle. And also that there is the alteration in the new serotonin and the norepinephrine link that is also be linked to the diabetic distress, leading to the different complication. Either you go for the micro and the macrovascular complication, but more importantly, the patient more have diabetic neuropathy. Now, on a nutshell, you can see what is the impact of the metabolic and the glycemic control by the diabetic distress. You can see the diabetic distress leading to the HPS activation, leading to the insulin resistance, and leading to the glycemic. It has got neuroendocrine impact, and that directly impairs the glucose metabolism. It has got the treatment resistance. High diabetic distress score may have the link to the higher HbA1c level also. It can have the vicious cycles, like already I have said, and also the neuropathy link that has been also associated with the diabetes distress. So the clinical key is the glycemic control is not purely behavioral. You have to understand it is physiological tied to the patient's emotional state. So addressing diabetes distress is a metabolic therapy. Now let's see what is the risk factors and clinical predictor of the diabetes distress. Now there are some clinical factors always the patient having the injectable therapy like the insulin, the GLP-RA, the patient is having different complication that can have risk factors for developing diabetic distress. It can have psychosocial factors, inadequate physical activity, dietary non-adherence, irregular monitoring that has an impact on the developing the diabetic distress, and some of the demographic features that will be very important for suffering from the diabetic distress. The female gender, unemployment, marital status, widow and divorced people are the clear predictor of suffering from the diabetic distress. Now, what is the clinical impact of this unaddressed diabetes distress? Now, it has come two consequences. It can have the behavioral consequence in the term of the poor medication adherence. Monitoring gaps will be there, and there is the lifestyle non-compliance will be there if you have unaddressed diabetes distress. Now, what is the physiological deterioration? If we do not treat the diabetes distress, it has going on to give you the suboptimal glycemic control. It has an accelerated complication in the form of the rapid progression to the retinopathy, neuropathy, and cardiovascular disease. And at the last, it will give you the reduced quality of life. So you have to treat the diabetes distress. Now let's have a look at the ADA 2024 guidelines about the diabetes distress. So they say that screen all patients for diabetes distress using the validated tools at the diagnosis, at annually, and whenever there is a significant change in the medication status or the treatment regimen, like when you are shifting from the patient to the oral anti-diabetic to the injectable one, from the injectable to the GLP-1 receptor agonist. So you have to definitely check it. So this diabetes distress will have a role particularly on beyond the glycemic control, and integrated care model is the needed. Now, how we can assess the diabetic distress? There are different validated screening tools available. DDS-17 and the PAID is one of the common tools we often use. The diabetes distress scale DDS-17, it has got the 17-item questionnaire, and particularly assessing the 4 domains: emotional domain, physician domain, regimen domain, and interpersonal domain. So if you have got the score of more than equal to 2, the patient is having moderate distress. If you got more than equal to 3, the patient has severe or the high distress. On the other hand, the ADA says the problem areas in diabetes, the PAID score is a better one, but Indian patient, the diabetic distress score is a better one. So you can assess the 20-item scale for the PAID score. The scoring range is 0 to 100. If it is more than equal to 40, the patient is suffering from high diabetes distress. Now, as we are very important, as we are practicing in India, the cultural difference will be there, so they have given importance to the different languages of the DDS-17 score. The Bengali version is also be there. Now, if you go for the clinical workup, how can go for it? That universal screening is important to one. You should annually screen all patients using the validated score like DDS-17 or the PAIR score at diagnosis and the major clinical changes. If the patient DDS-17 score is less than equal to 2, that is the cutoff. So you should give the general diabetes education, reinforce coping strategy and rescreens annually to prevent the patient developing the diabetes distress. Now, if the patient is having moderate distress, score is more than 2 to 2.9, in clinic behavioral intervention, refer to the diabetes, you can say the self-managing education program, you should definitely give the patient, and follow-up is important. But if the patient is having severe distress, the score is more than equal to 3, you have to refer to the patient to the mental health specialist. Comprehensive psychological evaluation is important, and you should go for the collaborative management as well. Now, how the interpret score for the targeted clinical intervention? Now, if say the patient is having high DDS score or high PAIR score, now you have to think about from where the high score is coming. If the patient, if you think that high emotional burden is important, so you should look at it, the emotional regulation technique, peer support and stress management is important. If the the score is coming from the high regimen distance, very important, review the treatment complexity, practical problem solving and use the DS-MES program. If the patient is having high interpersonal distress, you have to go and act against it. Family counseling is important, shared goal setting is important. Now, if the distress is coming from the high physician's distress, the doctor is the main distress. So, open discussion on communication, shared decision making and unmet needs. So, again, the precision, the intervention is important rather than the general intervention. Now, how you can go for this, the first line management of tackling this diabetes distress? I think you should remember this 4S framework. That is important. You should acknowledge that the patient having the diabetic distress. First of all, it is very, very important. Then you should assess what is the severity of the diabetic distress. You should use the DDS-17 or the PAIR score. Then you should go for the advice like the co-create problem solving strategies, simplify regimen is important thing and suggest the stress reduction also. And they should go for the arrangement. That means you have to monitor the patient, re-evaluate the distress, and you can connect the patient to the DS-MES program or the peer support program also. Now, if you go for the behavioral intervention for the moderate diabetes distress, I think that one of the 4 things that you can do is, the first thing is very important is the motivational and interviewing. That will enhance the intrinsic motivation and self-efficacy. The next thing, the collaborative goal setting. You should set your goal. It should be realistic, it should be achievable state. That is important. Problem solving therapy, like the 4-step process. Identify the problem, brainstorm solution, evaluate the option, and implement. That is also important. And also, the DS-MES referral, that is the diabetes self-management education and support is important as suggested by the ADA 2024. Now, when to refer? If the patient is having severe distress, then to refer? Let's see. If the patient is having severe distress, DDS-17 mean score of more than equal to 3 or PAIR score is more than equal to 40, you should refer to the patient to the mental health specialty. If the patient is already have comorbidities like the MDD, the patient is having general anxiety disorder, you should refer to the patient for the mental health specialty. If often the patient is having therapeutic failure, you are treating the patient for diabetic disease but no improvement, you should refer to the patient to the mental health specialty. And if the patient is having choice that the patient should need help from the mental health specialty, you should refer to the patient. Now, when it is referred to the patient to the mental health specialist, what they do, the best standard treatment, gold standard treatment is the cognitive behavioral therapy. Target the negative thought patterns regarding the diabetes self-management, reduces the fear of hypoglycemia and frustration with the regimen demands, and evidence-based improvement that is also been there. So that is the thing that you should understand. Now, use of technology. How important is this? Use of the technology like the digital health and the CGM. I think the mobile health technology is very, very useful. You can use the different apps like the MyDiabetes app is also there. Digital therapeutics helps to mitigate the emotional and regimen distance. And further, simplifies the daily tasks. Medication reminders and diet tracking is very, very important, very, very useful. CGM, I think it is a double sword. Yes, it reduces the uncertainty and fear of hypoglycemia with the real-time data. But again, if you are too much bothered with the data overload and misinterpretation, again can trigger anxiety. So you have to use the CGM very carefully. We can use the telehealth solution, facilitate the remote delivery of the CBT and counseling, very important, overcomes the geographical barriers in the resource limited setting as we are practicing in India, and it improves the convenience for the follow-up and the diabetic distress screening also. So definitely the digital health is helpful. Now what are the challenges? What are the barriers of treating a diabetic patient in Indian context? Always the low awareness and recognition is there. I'll just take one more time. The low awareness and recognition has always been there. There is always been the mental health stigma is also there. Lack of integrated care models has always been a problem in India. And always in India, we have the high patient load. So these are the challenges and the behavior. Now in conclusion, integrating psychosocial care, the clinical takeaway is the diabetic distress is a prevalent and distinct clinical entity affecting 42% of Indian patients. Routine screening is important as suggested by the ADA 2024. You can use the DDS 17 or the PAID score. You can use the 4S framework, acknowledge, assess, advise and arrange for the primary management. And tailored behavior intervention significantly improve not only the diabetic distress but it improves the age-based and quality of life. Now the paradigm shift has occurred, the transitioning from treating diabetes in the patient to caring for the person with diabetes, that is important. Integrating psychosocial support is no longer optional, it is fundamental to the metabolic support or metabolic success. Thank you for your patience hearing.
Thank you, Dr. Brera. We would like to invite some questions from the audience. Dr. Shaha,
You can come up, please. Okay, any questions from the audience? Okay, I'll just ask Dr. Kaushik Shah one question. You have talked about the drugs which cause hypoglycemia. We cannot get away with short-acting insulins because that is a necessity, but definitely sulfonylureas, they can actually take a back seat now because of the fact that sulfonylureas do not address any of the ominous octet factors. They can cause hypoglycemia, and at the end of the day, they are doing nothing better than reducing the glycemic numbers. So, is it the time to replace with GLP-1 RS or SGLT2 or DPP-4 even though they are slightly expensive, but we can replace.
Okay, I think theoretically your answer is right, but practically, if you practice in diabetes, I think it's very difficult to get away of the sulfonylurea, because although we have got a lot of drugs like the SGLT2 inhibitors, DPP-4 inhibitors, if you replace the DPP-4 inhibitors by the GLP-1, but still most of the patient does not have the glycemic goal met. That means the HbA1c level is high and the fasting and the PP blood sugar is high. So in that situation, I think we have got the two options, as you said, the insulin and the sulfonylurea. Now, the important thing is that in India, it is very difficult to start the insulin whenever it is required. I think because of the injection phobia, not by the insulin phobia. So in that situations, I think you don't have any options to start with the sulfonylurea. But I can tell you, in spite of using the sulfonylurea in my clinical practice, I think we should not have as projected hairs. That means there is a huge amount of hypoglycemia, and that is because of us. Not that the sulfonylurea is a culprit. I think if you use the sulfonylurea very judiciously, taking care of these risk stratifications, that means patient giving the history, patient giving all these parameters, but still you are not reducing the dose, then probably we have got the more incidence of hypoglycemia. So don't say that the sulfonylurea is a culprit. You require the sulfonylurea in your clinical practice, you require the insulin, prandial insulin, but you have to use very judiciously in certain situations where I have said regarding the special situations, special precautions, special areas. Then probably you can reduce the hypoglycemia. No way in your clinical practice in type 2 diabetes, if you control the diabetes and there will be no chances of hypoglycemia, it is very, very absurd, very, very unusual thinking. That's my opinion.
Yes, very true, Dr. Shah. Actually, just like intensification, de-intensification is also very, very important. Yes. Whenever we treat our patients.
So,
yeah. Thank you, sir, for this beautiful lecture, consecutive lecture. Just one question: when we see hypoglycemia in our patient, how it is important to take the medication history, non-diabetes medication history. Very importantly, we had found very recently we had prepared one case series where over-the-counter ofloxacin plus something, norfloxacin plus something had result into hypoglycemia unless the patient were on certain drugs like DB4 inhibitors, metformin. But patients were having hypoglycemia in the level of 3 of them have severe hypoglycemia.
Yes, absolutely. And in this list, I think one of the important agent is also linezolide. I think in case of diabetic food, most of the patients are getting the linezolide without any modification of the dose of the oral hypoglycemic drugs, and that may causes the hypoglycemia in certain situation, and that has to be taken care. This is a very important thing to be remembered.
Dr. Saha, if I may add, remember the time during COVID we used HCQS, blanket HCQS? A lot of patients developed hypoglycemia because of HCQS.
Yes.
Number one. Number two, as we were discussing regarding sulfonylureas, you still, I think everybody knows, Glynis 5 milligrams is available at 10 rupees. For our not so well-to-do population, we cannot just discard sulfonylurea.
Yes, and that's the area, because otherwise I think sulfonylurea is a very good drug to have. I think everybody in this audience, I think, use the sulfonylurea. It is not that we are not using, and using in a percentage that has been shown, that is around 30%. I think in my population also, I think 20 to 30% patients are on sulfonylurea.
আমার কোনো প্রশ্ন নয়, এর আগের ফটোটা, এর আগেরটা, এটা মানাচ্ছে না।
Why?
মানাচ্ছে না।
Why, sir? Please explain.
মানাচ্ছে না, কারণ এই এজে তো ডায়াবেটিস ডিপ্রেশন কম হয়, উল্টোটা হলে ভালো হতো। আমরা যা মনে করবে যা ডিসপ্লে করব সেটা যেন ম্যাচ করে।
Okay.
Okay.
Very
So
good
that is different
presentation,
issue. Okay.
Dr. Bera. I just want to comment one thing, because many of our patients are diabetic patients are having erectile dysfunction.
Yes.
And because of erectile dysfunction, sometimes this diabetes disease comes. So what is your comment on
Yes,
that?
sir. Actually, you have to definitely ask the patient for this, because the stigma is there and the patient is very hesitant to give all the history. So definitely this is one of the aspects you should have.
Sometimes correction of, if we correct the erectile dysfunction, distress can go.
Yes, many of the patients can have that.
Just one last question. Counseling of a young diabetic patient just diagnosed and knowing that the patient has to carry on the disease for all his life, how stressful it can be for a 25 to 30-year-old?
No, definitely. We are just asking for the newly married couple,
For any youngster of 25 to 30 years.
I think there is the score is there, the DDS 17 and the PAID score.
I think you have a paper on that.
Yes.
You have a publication.
So definitely the important is you have to ask the question. I mean, ask the patient that whether the patient is having any depression and all these things about the diabetes.
Okay, thanks to all the speakers. I'd like to invite any mementos or not. Like to ask the organizers for any felicitation of the speakers. No, or we can close it.
Okay, close.
We can close this.
Okay, so we will move on to our next session. The chairperson for this session is Dr. Taposh Bandyopadhyay and Dr. Ambarish Bhattacharya. So please come on stage, sir.
For the second session, we will be calling on stage Dr. Mudit Savarwal for the first talk. He is the director and consultant diabetologist at Dharma Diabetes and Metabolic Clinic. And the topic is inpatient glycemic control, bridging the gap between guidelines and bedside practice. He is from Fortis LFM Multispecialty Hospital, New Delhi. Dr. Mudit, please.
Thank you so much, sir. Thank you, Dr. Supratik and Gaurav, sir, for this kind opportunity. And thank you, EMOCON, for inviting me here. So I'll be talking about inpatient glycemic control. It's a huge it's a broad topic, but then I'll try to justify the time I've been given to discuss that. So we know that this is a huge challenge in our day-to-day practice. So we have about 30 to 35% admitted patients who already have diabetes, who have already diagnosed with diabetes on admission. About 33% patients are without diabetes and they develop stress-related hyperglycemia when they get admitted in the hospital, and that's of course a diagnosis which happens during the admission. And then there is 2 times more complication risk in patients who have diabetes or probably develop diabetes than those patients who do not have diabetes in our hospital. Now, of course, hyperglycemia during hospitalization is generally related to prolonged stays, increased infection rates, and higher mortality, and we as clinicians know about that. This is pertaining to both ADA and RSSDI guidelines that define the hospital hyperglycemia as majorly those who have blood glucose more than 140 milligram per deciliter on admission, and then of course additionally highlights the higher burden of diabetes in India. Now, why it matters? That's an important question. Now, because of increased morbidity, because there are higher infection rates, impaired wound healing, and there is surgical side complications, which is more common in diabetes patients. Then, of course, prolonged stays in the hospital, and that's majorly increases the economic burden on the patient itself, and of course, the healthcare systems in the country. There is increased mortality in patients with diabetes because of poor glycemic control, which itself is a predictor for more morbidity and more complications in diabetes. And then, of course, intervention window increases, where admissions becomes a critical opportunity to optimize the long-term diabetes management in all these patients who are inside the hospital with diabetes itself. Now, there are some core principles of glycemia management which we as clinicians have to pertain to. First, safety first, and I know hypoglycemia has been discussed in length in the previous sessions, but then of course both hypo and hyperglycemia becomes equally important and more towards hypoglycemia when we talk about diabetes management, especially in the hospitalized patients. Individualization of care, where tailor-made targets and the corresponding treatments have to be made to control or prevent comorbidities and maintaining nutritional status and the treatment goals for all these patients who are hospitalized. Then evidence-based care, we're adhering to current ADA, Endocrine Society, and majorly our own RSSDI guidelines become something which is very important in our practice. And then of course it should be a team-based approach where physicians, nurses, pharmacists and dietitians must collaborate among each other. So it's a teamwork to actually both prevent and control complications of diabetes in the hospital. There are certain key guidelines which we follow generally. So first is Endocrine Society guideline, where primary framework for non-critical ill adults emphasize the basal bolus protocols for insulin, which is majorly the cornerstone of treatment and hypoglycemia prevention. Then of course ADA, which we all follow, apart from RSSDI guidelines, where annual standards of care include dedicated inpatient chapters with target ranges and monitoring recommendations. And then of course NCBI and RSSDI guidelines, which is basically comprehensive evidence that synthesize both adult non-critically ill patients and the bedside practice references. Now these are generally our own RSSDI 2025 guidelines, which is it's specific to Indian system. Now the glycemic targets generally include glucose between 140 to 180 in critically ill patients. Non-critically ill patients, it can be between 100 to 180, majorly to prevent hypoglycemia. That's more critical to us. The hypoglycemia threshold is less than 70 for grade 1 hypoglycemia and less than 54 milligram per deciliter in grade 2 hypoglycemia. The preferred therapy is insulin management. That's the cornerstone of diabetes management for patients in hospital. Basal bolus subcutaneous insulin for non-critically ill eating patients, and IV insulin infusion for critically ill patients. And then of course OADs and SGLT2 inhibitors are generally withheld, majorly SGLT2 inhibitors, because we want to prevent euglycemic decay in all these patients. Monitoring is extremely important, so ISO certified POC glucometers are standards. CGM is something which is coming up as an emergent adjunct to non-ICU patients. And then of course time in range is endorsed by various bodies. HbA1c on admission if in case it was not done in the past 3 months. And then of course there are special circumstances where in perioperative you have to hold OADs and SGLT2 inhibitors at least 24 to 48 hours before surgery. Glucocorticoid induced hyperglycemia where NPH or adjusted bolus dosing needs to be done. Renal failure, we have to reduce the insulin doses and metformin if GFR is less than 30. And of course, parenteral patients who are on enteral and parenteral insulin, regular insulin protocols, maintaining the target between 140 to 180 is critically important. Now again, following up the same slides, and I'll emphasize more on the glycemic targets because these are most important for us as clinicians when treating hospitalized patients. Now both AD and RSSDI guidelines, they endorse glucose targets of 140 to 180 in critically ill patients and 100 to 180 in non-critically ill patients, where a pre-meal glucose can remain less than 140 and random glucose can remain less than 180. Now of course hypoglycemia is 70 and 54 in grade 1 and grade 2 hypoglycemia respectively. Time in range is again an important factor which can be added to point of care testing. But the target is to maintain the glucose more than 70% in range, which is between 70 to 180, pertaining to an HbA1c of 7%, which we want to target. And of course, emphasizing avoidance of overly tight control. Remember, we don't want overly tight control because we are more concerned about hypo than hyperglycemia, especially in elderly patients. Now, of course, monitoring strategies may include point of care testing, which is a standard for most patients. Both RSSDI and ADA recommends ISO compliant glucometers that are validated for hospital use. And of course, performing both pre-meals and bedtime glucose with frequency guided by clinical status. CGM is again, it is recognized as an emergent adjunct to ICU, to point of care testing in ICU settings. It can be used for replacement, not for replacement, but then it can be used in Indian hospitals as a resource variability. Of course, monitoring is between 4 to 6 hourly, that's what we usually do, but 1 to 2 hourly in patients who are critically ill or those who are on IV infusion. Talking about time in range, now it should remain the time in range should remain at least more than 70% in range, that's 70 to 180 milligram. checking HbA1c before admission if not done within the last 3 months, along with that is basically endorsed with RSSDI and ADA guidelines. Now, as I mentioned before, in pharmacological management, insulin is the cornerstone of diabetes management in hospitalized patients. So it is preferred for most critically ill patients. That's the basal bolus regime, which is preferred for most critically ill patients. Sliding scale is not followed at all. So again, a basal bolus plus a mealtime glucose, mealtime insulin variation with correction doses is probably preferred. Now, of course, IV infusion in patients who are critically ill and in ICU, and maintaining a glucose of between 140 to 180 and monitoring the blood glucose every 1 to 2 hourly is the protocol. Now again, transitioning from IV insulin or infusion to subcutaneous insulin, that's basically overlap. So the overlap IV and subcutaneous insulin by 1 to 2 hours. You have to administer basal insulin 2 to 4 hours before stopping the IV infusion to prevent rebound hypoglycemia. And of course, ADA recommends structured transitioning protocols with clear handoff documentation. In non-insulin agents, so again, OADs are generally not recommended in patients who are in the ICU. SGLT inhibitors should be withheld, and GLP-1 RAs are also generally withheld. So selectively, we can use DPP-4 and metformin if in case required in these patients. Now, talking about basal bolus versus corrective insulin only. So again, basal bolus is preferred route of insulin management in patients who are non-critically ill. And again, corrective doses one can consider for patients with unpredictable oral intake, short procedures, and very low insulin requirements. Avoiding sliding scales at all time is generally recommended. Now, of course, the protocol which we follow is reducing the basal insulin dose by 20% if the glucose remains below 100, increasing the basal insulin dose by 10 to 20% if the glucose remains more than 180 milligram per deciliter. For NPO patients, give basal insulins at 50 to 75% of the usual dose. So if the patient was on 100 milligram, then if the patient was on 30 units, then we can start with about 15 to 20 units of basal. Again, following up with the IV and then subcutaneous insulin, mealtime insulin. Now, of course, one has to use a protocol-driven approach. In special population, so again, in perioperative management patients, both ADA and RSSDI 2025 guidelines, the target for blood glucose is between 140 to 180 milligram per deciliter. One should be holding OADs and SGLT inhibitors at least 24 to 48 hours, when we prefer 48 hours in general, pre-op. Use of IV infusion for major surgeries and monitoring the blood glucose every 1 to 2 hourly is generally recommended. Once the surgery is done, maybe after 24 hours, you can resume to subcutaneous basal bolus regime. In glucocorticoid induced hypoglycemia, which is RSSD, so it is common in oncology, rheumatology, and post-COVID patients. So again, once daily morning steroids is generally there, so we can use NPH or increased afternoon bolus. High dose in patients who are on high dose of steroids, a basal bolus or an IV insulin is generally preferred. In renal failure patients, if the patient's GFR is less than 30, then basal bolus of insulin regime is generally preferred. And again, so we can prefer glycated albumin over HbA1c in dialysis patients. In those patients who are on enteral feeds or parenteral nutrition, monitoring the glucose for every 4 to 6 hourly, and those patients who are generally pre-op or post-op or NPO, then 1 to 2 hourly should be preferred, and especially those patients who are on IV infusion insulin. Now, how do we bridge the gap between guidelines to bedside? So again, one has to have standardized order sets where pre-built insulin ordering pathways to can reduce the variability and prescribing errors at point of care. So maintaining EMRs, maintaining EMR protocols in the hospital for all the doctors generally is preferred. Now, of course, talking about clinical decision support, so EHR integrated alerts and dosing calculators generally plays a guiding book for most of the doctors in the hospital. Now, of course, nurses are the frontline workers. So again, for the frontline nurses are their education and the protocol-driven pathways should be designed in hospitals for the nurses to follow. Now, of course, it's an interdisciplinary round. So again, interdisciplinary work. So again, daily team reviews ensures glycemic management that should be integrated and not in a sliding manner for maintaining the overall status and overall control in the hospital settings. Technology is extremely important. So again, insulin pumps can be introduced. So again, that can continue pre-admission CS2 therapies wherever feasible. It requires hospital-specific protocols and trained staff overnight, and frankly speaking, it is not there probably in most of the places. CGM devices can be integrated as an adjunct to point-of-care testing to provide real-time glucose trends, hypoglycemia alerts, and time and range protocols. And of course, glycemia management platforms like EHR integrated with CGMs can be widely used and as an insulin dosing decision support. Prevention of hypoglycemia, I'll not get deep into it because it's already been discussed. You can reassess insulin doses when oral intake is reduced, communicate NPO status to the entire team, and of course, just 30 seconds please, and rapid glucose treatment which is available at the bedtime following the protocols we have. Diabetes education is extremely crucial. So again, medication adherence with giving corrective insulin techniques, dosing and storage. Self-monitoring of blood glucose, again the patient has to discharge someday. So of course, when and how to check glucose, that's important. Diet counseling, so carbohydrate awareness and meal planning accordingly is extremely important. Protein intake, fiber intake has to be integrated in that. And sick day rules, when to call and when to adjust and how to act and when to act, it becomes extremely important for the patient education. Now future directions, so again CMS quality mandates, so there is mandatory reporting of severe hypoglycemia and hypoglycemia events that drives institutional accountability. Closed loop systems, so again automated insulin delivery adapted for inpatient environments which can be adapted, which are generally in early trials show promising safety results. AI and predictive analytics using CGMS and closed loop systems and developing machine learning on the basis of that on pre-built protocols is being developed. And again, personalizing strategies including leveraging genomics, metabolomics and advanced data to individualize glycemic targets to a patient level is also being studied. Now at the end, again, I would like to close my topic with 3 things. One is the goal is to maintain safe, effective glycemic control for every hospitalized patient from admission to discharge planning and beyond. Now we have to integrate evidence-based like guidelines with practical bedside tools through a collaborative technique-enabled team approach. And then of course, the impact of both of above will be fewer complications, shorter hospital stays, lower costs, and meaningful better patient outcomes. Thank you.
Because of lack of time, we will take questions at the end of the session. May I now call upon Dr. Anil Virmani. He is from Jamshedpur. He is a consultant physician, cardiodiabetologist. He is the Dean of the Indian College of Cardiodiabetology and the CEO of Clinical Cardiodiabetes Society of India. I request Dr. Virmani, he will speak on stress hyperglycemia versus undiagnosed diabetes in hospitalized patient.
Sir, please start.
There's no slide changer? Excuse me, there's no slide changer. कैसे move करना है?
একজন এখানে আসুন না, একটু দেখিয়ে দিন।
They don't have a slide changer. I don't know how to move this. Okay. This one. Good morning to all of you, honorable chairpersons and dear friends. The topic that I've been given today is to talk on stress hyperglycemia versus undiagnosed diabetes from before admission in hospitalized patients, no disclosures. Now, we all know that patients with diabetes have a 4 times greater risk of hospitalization with longer hospital stays and greater chances of readmission compared to patients without diabetes. There are some patients, hospitalized patients, who can develop hyperglycemia without a history of pre-existing diabetes, and this is what is known as stress hyperglycemia, and it came into limelight during the COVID era. This is also associated with poor hospital outcomes. What actually happens is that the stress of acute illness and surgery in hospitalized patient increases the production of counter-regulatory hormones like cortisol, glucagon, and growth hormone, and pro-inflammatory cytokines like tumor necrosis factor alpha and various interleukins, ultimately leading to increased hepatic gluconeogenesis, muscle catabolism, and lipolysis. And these changes can induce acute hyperglycemia with and without a history of diabetes. The ADA-AC consensus has defined stress hyperglycemia as an acute blood glucose rise of more than 140 milligram percent in hospitalized patients without a history of diabetes. The prevalence is around 32% in critically ill patients in ICUs, 30% in non-critically ill hospitalized patients, and up to 60% in patients, hospitalized patients after cardiac surgery. And the various factors associated, especially in critical illness, are the presence of stroke, multi-organ dysfunction, sepsis, pneumonia, chronic kidney disease, CNS infections, chronic liver disease, and seizure patients. It is associated with a prolonged hospital stay compared with normoglycemic patients. Usually it is transient, and once the stress resolves, this also goes away post-illness. On the other hand, undiagnosed diabetes are patients who have persistent hyperglycemia with an A1C of more than 6.5%, indicating previously unrecognized diabetes. To differentiate between these two, the Endocrine Society guidelines recommend a measurement of A1C on admission. So the key diagnostic tools are: you have the admission blood glucose measurement, you have the A1C at admission. If more than 6.5, it is likely to be patient is likely to have pre-diabetes. If it's a normal A1C with high glucose, it is most likely stress hyperglycemia. Now, what is the clinical significance? As I said, this is associated with higher complications in both ICU and non-ICU patients. And systematic reviews have shown that it predicts a worse mortality and morbidity in critical illness. A meta-analysis showed that these patients had more than 3.5 times the risk of developing diabetes later on. But this was criticized because it was uncertain because of statistical and clinical heterogeneity among the included studies. However, a Scottish retrospective cohort study showed that elevated glucose during admission
predicts incident diabetes over 3 years with 1.5 times higher mortality. The basic purpose here is to inform patients of their long-term risk of diabetes and to target lifestyle interventions for prevention of them getting diabetes. If you look at the outcomes, stress hyperglycemia is associated with higher complications, long-term mortality, independent of the diabetes status. And we must remember that stress hyperglycemia can also occur in non-diabetic patients, a fact that is sometimes overlooked. So it is very important to make a proper diagnosis when you see the patient for the first time who's hospitalized. Russo et al. Found that the patients of stress hyperglycemia have a better glycemic control with a higher percentage of TIR, that is 35% compared to 25%, a lower insulin usage, 26% compared to 46%, compared to those patients who are known diabetes. Both groups, however, showed similar mortality rates, and stress hyperglycemic patients had fewer hypoglycemic episodes. The key message here is that though both of these signal poor outcomes, defining diabetes status influences follow-up care. The clinical management has been discussed very well by the previous speaker. I'll just give you the important key points. These are from the ADA Standards of Care 2026. The screening and diagnosis, we must have a universal glucose and A1C assessment at admission. And we must perform an A1C test on all patients with diabetes or hyperglycemia that is having a random blood sugar of more than 140 if no A1C test has been available from the previous 3 months. Insulin is the drug of choice, and it is better to have a dedicated diabetes team treating these patients. Insulin is often initiated or intensified for treatment depending on a threshold of blood sugar more than 180 milligram, confirmed on 2 occasions within 24 hours, for the majority of critically ill individuals, that is those in the ICU. Even those who are not in the ICU, you can add glucose-lowering therapies along with insulin if the blood sugar has a more than 180 milligram % confirmed on 2 occasions. Once therapy is initiated, the glycemic goal is 140 to 180 milligram. In critically ill individuals, that is those in the ICU. However, a more stringent individualized glycemic goal may be appropriated for selected critically ill individuals if they can achieve it without significant hypoglycemia. On the other hand, in non-critically ill individualized patients, the glycemic goal of 100 to 180 milligram is recommended if it can be achieved without hypoglycemia. And those who are on CGM, the use of CGM should be continued during hospitalization, and however, the blood sugar should be confirmed with point-of-care blood glucose measurements for when you are taking decisions regarding insulin dosage and hypoglycemia assessment. These patients should be followed up post-discharge because they may have a higher risk of type 2 diabetes. So the key messages are, we must remember, stress hypoglycemia is common and often signals severe illness, and it carries a risk of future diabetes development, so these patients have to be monitored. Undiagnosed diabetes should be identified early on to tailor long-term care. And A1C is essential to distinguish between stress hyperglycemia and undiagnosed diabetes mellitus. Thank you for a patient hearing.
Thank you, sir. You have finished well ahead of time. Few questions or comments from the audience? Thank you. If no comment, thank you, sir, for your excellent talk. May I invite Dr. Arun Raghavan a consultant diabetologist and metabolic physician at Revivo Clinic. And he will be speaking on a very interesting talk, GLP-1 receptor agonist and SGLT2 inhibitors in peri-operative setting, to stop or not to stop in peri-operative setting. Dr. Arun Raghavan, please. A slight change in schedule. You will be speaking, sir? Okay. A metabolic oration, a 32 years odyssey in diabetes and pregnancy, Indian perspectives and global relevance. Dr. Sunil Gupta from Nagpur. He is the National President of Diabetes in Pregnancy Study Group in India, DIPSI. He is the National Vice President of RO, National Treasurer of RSSDI Headquarters, and he will be speaking on diabetes and pregnancy, a 32 years of odyssey in Indians' perspective, global relevance. Dr. Sunil Gupta, sir, please. He is the National President-elect, RSSDI 2026. Sir, welcome, sir. Because some change in schedule, probably people are unprepared.
It's an absolute honor to have with us Dr. Sunil Gupta, who is the President-elect of RSSDI. He is receiving the metabolic oration from our association, AMOCE, and it's an absolute pleasure to honor him. Can we have, the yeah. All right. Do you have the slide?
Thank you very much, Supratik, and thank you for this honor. And my today's talk is on this metabolic oration. I'm really feeling honored to have this, and not only the young brigade who was there on the dais, but also with the hands of Dr. Ramchandran, who is our mentor and a part of our extended family of diabetologists across the country. So thank you very much. And my today's oration talk is on my original work on diabetes in pregnancy, Indian perspective and global relevance. So congratulations, team Metabolic Obesity and all office bearers, thank you very much. And before I forget, I invite every one of you to please join us on 19, 20 and 21st of June for Hello Diabetes Academia. And also the national meeting of RSSDI in the month of November, 19 to 22nd November. And I'll be happy to welcome you all along with all my, the team of RSSDI headquarters. We have sitting with us here Vice President Dr. N.K. Singh. We have many more people here in the audience who are the part of the EC. And we all will be there to welcome you along with Anuj Maheshwari and Rakesh, Dr. Prasanna Kumar and LSM. There's no conflict of interest for this oration. We'll have introduction, burden of HIP, very brief. I'll certainly fail in my duties if I don't recognize people because of whom I'm standing here in front of you in last almost 30-35 years of my journey here. And global and Indian perspective of HIP, what work we have done in the past and which has its clinical relevance when it comes to you treating a case of HIP. So we'll have some evidences on GGI, GDM, pre-JDM, type 1 diabetes, type 2 diabetes, twin pregnancy, and even obesity. And then our thirst area as a mass awareness. So my gratitude to Dr. Vijay Asgaonkar, who actually have started my career as a diabetologist long back in 1991 and 92. From Mumbai, then Dr. Sam G.P. Moses, I got introduced to him in one of the meeting in Hyderabad, those days of RSSDI, where we hardly had 120, 130 participants, and I was one of the part of it during those days. And of course, Dr. Seshayya, who's a mentor for us and is guiding force for diabetes and pregnancy in this part of the country, this part of the world. And of course, the Dr. Shaukat Sadiko, Dr. Siddharth Shah, Dr. Chandalia, Dr. O.P. Gupta, Dr. B.B. Tripathi, across the country, if you say Chennai, Mumbai, and then you have Ahmedabad, Dr. B.B. Tripathi from Cuttack, Dr. Ved Prakash Mishra from Nagpur, Dr. B.K. Sai from Hyderabad, Dr. A.K. Das from Puducherry, and Dr. Patil, my teacher of my college days, of course, Dr. V. Mohan, Dr. Aspi Irani, and Dr. Deepak Dalal. These are all pioneers who have made me, because of whom I am here. And of course, Dr. P.V. Rao from Hyderabad. And Dr. Shashank Joshi, always guiding me somewhere, and then Bansi Bhai. So we all work as a team across the country for the cause. My journey started almost long back when I started my practice in 1992 and then 94. And the first meeting of diabetes in pregnancy I organized almost 26 years back in 1999, when Dr. Sheshaya came by train from Chennai, almost 24 hours train those days, starting in the morning and reaching Nagpur next day, almost 20 hours. And he delivered one oration, Sen Gupta oration, and that has ignited light in me that I should work in these lines. And then the first time DIPSI meeting has come out of Chennai was Nagpur. The third DIPSI which was organized, it was in 2004, and I was the organizing secretary that time, and the whole team of DIPSI had come and multiple national speakers were there. And those days, Dr. Jitendra Singh, who is now the Union Minister, was the joint secretary of DIPSI with me. So we are sharing the chair of the joint secretary of National DIPSI those days, and this is a picture of 2008 when he came to Nagpur for DIPSI. So let me talk about the introduction. I feel history-wise, if you go through before 1921, before the discovery of insulin, practically the morbidity and mortality of especially type 1 diabetes was very, very high. Hardly any type 1 diabetes used to think of having pregnancy, and pregnancy was practically unknown in type 1 diabetics. And many of the type 2 diabetes having a lot of very high fetal morbidity and even maternal morbidity and mortality. So, but after that, of course, the things have changed. This is some data from 1909 that 50% of the maternal mortality, 27% immediate, 33% next 2 years, and almost 41% pregnancy loss. So pregnancy were rarity to begin with, because most of the women of reproductive age died within a year or two after the onset of the illness. Now if you see this data of IDF says almost every fourth woman in our country in pregnancy might be having some kind of hyperglycemia. Pregnancy, Southeast Asia, the prevalence is very high. Somewhere it is 20%, in north and extreme north it seems to be even less than 10%. So multiple regional variations we have. And this is a data of ICMR which it was published in 2023 June, where you have shown the dysglycemia proportion, which is pre-diabetes and diabetes. So if you have almost 10.1 crore diabetes and 13.6 crores pre-diabetes, and if you add both of them together, there's 23.7 crore people above 18 years of age have dysglycemia. That means every fourth person above 18 years of age have some kind of dysglycemia, and all those women amongst this group are the childbearing age women's, and they all are likely to be exposed to the physiological stress of pregnancy and likely to become GDM. And so if you go this way or you go this way, it comes to almost every fourth woman is likely to have some kind of dysglycemia in pregnancy. And we know that it's a vicious cycle. If you control hyperglycemia well during the pregnancy, you can prevent the development of diabetes and non-communicable diseases, obesity, hypertension, coronary disease in the offspring of diabetic mother, as well as the mother also can be protected by addressing in the early stage once we know that they have GDM. So the postnatal follow-up is equally important. And there are also data that those who are known type 1 or type 2 diabetes, you have to focus from the preconception, because preconception or periconceptual hyperglycemia is more dangerous, more important than the HbA1c at the time of diagnosis of pregnancy. So even that is important. So preconceptual, the oocyte maturation, the follicular development, conception, fertilization, embryo growth, gestational and sucking period, and even the sperm cell maturation. A lot of things are important when you are being labeled as type 2 or type 1 diabetes for whenever you plan pregnancies. So 2 generations are protected. One is the women who is likely to develop diabetes in future, and the child who is born to these mothers is likely to develop non-communicable disease in their adolescent as well as adult life. So if you focus pregnancy, you are actually expected to save 2 generations. And this is the recent diagram proposed by FIGO, that we have an umbrella term called HIP, hyperglycemic pregnancy, subdivided into 2, diabetes in pregnancy, and GDM. GDM typically appearing in pregnancy disappears after delivery, and then there will be rare situations, some of them have never diagnosed and have been diagnosed during pregnancy and screening, and they are also supposed to be treated as a pre-gestational diabetes. And those DIP is diabetes in pregnancy, more severe cases, type 1 or type 2 diabetes, or planning pregnancy and have become pregnant. So there are 2 different groups, and the treatment strategy differs in both of these groups when it comes to choosing the therapy. There are also newer terminology like conventional GDM, typically diagnosed between 24 to 28 weeks of pregnancy. Overt diabetes or diabetes in pregnancy, which I told you just now, those who have been diagnosed for the first time but have been diagnosed during pregnancy but have pre-existing diabetes which has never tested. EGDM is a new terminology. Professor Mohan and many people across the world are doing on this particular area, that if the GDM has been diagnosed before 20 weeks of pregnancy, we call it as EGDM. Mild GDM is another new term, good terminology, which was used by DIPSI in 2006 and 2003, and that was named with given different names, and we have to even focus on that. Screening diagnosis, again, I will not be going in detail of it, but DIPSI guidelines have been approved by Government of India in 2014, 2018, as well as SOP has come in 2024, and most of them they are following it. But you have global guidelines which are being followed by across WHO, IDF, US ADA guidelines, as well as the Australian guidelines. So many of the countries, European guidelines, they are following IDPG guidelines. Again, you have to go for fasting. If fasting more than 92, give 175 gram glucose. If it is 1 hour is more than 180, or 2 hour more than 153, you call it as GDM. 2024 guidelines of Government of India again says that it's the 75 gram glucose irrespective of the time of the meal. Just give it to the women when she comes to you. Take 2-hour test. If it is more than 140, diagnosed as GDM. So again, I'm not going detail of it because that's not my primary talk today. Gestational glucose intolerance is one thing which is important. Your cutoff of 2 hours for your glycemic control is 120. 1 hour less than 140 should be a target. Fasting should be less than 90 or 95. So when any reading after glucose challenge goes above 120 should also be taken as caution. So between 120 to 140, you call it a gestational glucose intolerance. There are various countries, whereas Australia, they call it as, New Zealand, they call it as borderline GDM. Netherlands, they call it as mild GDM. The Canadian guideline, they again call it as IGT of pregnancy. So different people, they call it and everyone wants to treat it. And we have documented it from our own, one of the papers presented in IDF. And we have seen that those patients who have mild form of GDM, which is 120 to 140, if they have history of bed obstetric history, and if you treat them properly, you can reduce the risk of fetal losses and fetal morbidities to a large extent, from almost 36% to less than 3%. Glycemic targets is as I told you, 2 hours should be less than 120. You also have now CGM targets. So the TIR, time in range for pregnancy, is between 63 to 140. And for GDM and type 2 diabetes, you should try to achieve more than 90% of TIR. So reading should be between 63 to 140 in pregnancy, unlike in non-pregnant state where you start from 80 to 180. So that's one change. But for type 1 diabetes, you have to keep it up to 70% TIR, but type 2 and GDM try to keep it between 90%. Therapy-wise, of course, 70% of GDM will do well on diet and exercise. The rest of them may need pharmacotherapy. Metformin is being approved by Government of India, DIPSI also. Some of the data says up to, from 20 weeks of pregnancy. Last year in 2024 DIPSI guideline now say up from 12 weeks. If you go through NICE guidelines, European guidelines, they say from pre-pregnancy till delivery you can give metformin. But insulin doesn't cross the placenta, and that is why insulin remains the drug of choice when it comes to pregnancy, because all of the oral drugs, they are going to cross the placenta. Now, around data on insulin therapy, so we have some data on insulin and pre-gestational diabetes and LADA. So we'll just go through a simple case. There's a lady, 28 years. During COVID, she became pregnant. At the time of diagnosis of pregnancy, her HbA1c, I feel 12.9, and ultimately she had IUD and she lost that baby. She was referred to us after that, and she was kept in basal bolus therapy. She came to Nagpur. She went back from there back to Madhya Pradesh, and she was maintaining her HbA1c to around between 6 and 7, 6.56 and 6.07 if you see here. And she again she again came back with the pregnancy, with the HbA1c this time, which was well controlled diabetes on basal bolus therapy, 6.07. Now, my purpose of showing this slide is how does the insulin requirement goes once you preconception, from the conception, mid-pregnancy, at the time of delivery, and postpartum. So you just go through this. Preconception dose of this LADA or type 1 is 0.7 units per kg body weight, which went up from there to up to 36, which is around 2.1 unit per kg body weight, almost 3 times from the pregnancy till delivery. Postpartum, 10 weeks, 10 days is only 0.32. That means 50% of the preconception dose. So you don't have to be very much hurry. You go back to the pre-pregnancy dose, otherwise she'll end up into hypoglycemia. And the postpartum follow-up, almost 30 days she came back to the original doses. So if you go through this data or this graph, you can easily appreciate how the insulin requirement goes up from the early 44 units to almost 132 units, came back to 20 units at weekend, and again went back. So I feel it was 30.
It was the previous adjustment. You can carry.
Okay, yeah, because I thought. And this, of course, intrapartum insulin infusion was given. So that's one thing which we have to learn, that at the time of delivery, those who are on multiple doses of insulin should use the infusion pump at the time of delivery. To try to keep the blood glucose between 170 to 120, and that to avoid neonatal hypoglycemia. This is one case. So then, after getting acquainted with that, we have compiled the data and retrospective data of type 1 diabetes pregnancy. So we had the data of around 33 pregnancies, and what we have found is the preconception requirement in this type 1 women were 0.85, and then it was a LADA, so possibly the requirement little less. Preconception dose, which again went up to 1.2 and then come back to 0.5, and then the postnatal is 0.7. We presented this oral paper in American Diabetes Association. And then this is data on type 2 diabetes. So type 2 diabetes, again, we did not, if you go through any of the literature on insulin therapy in pregnancy diabetes, you will find all older things which is being mentioned. 30% short-acting, 70% long-acting, sometimes they mention 50% short-acting, 50% long-acting, doesn't suit in pregnancy. Gestational diabetes, you need only short-acting insulin because gestational diabetes is postparental hyperglycemia. Hardly you get fasting, usually 70s and 80s. So you don't need long-acting insulin at all. But the literature still mentions that you use such kind of, I have a table, unfortunately I have not kept it here. So that's why this data is very much pertaining to our clinical practice. Pre-gestational type 2 diabetes, first trimester require around 0.5 unit per kg body weight. By the time it goes up to the third trimester delivery, it's almost 0.8 unit per kg body weight. So this is how that, and this per kg body weight is pre-pregnancy per kg body weight. Another important thing is from central India, what we have found is maybe different in South India, that the before dinner or pre-dinner dose was found to be the highest versus the pre-breakfast and the pre-lunch doses of insulin. That means the post-dinner hyperglycemia was remarkably or significantly higher versus the post-breakfast hyperglycemia, and that has also been documented, and we have seen it's the calorie intake of these people from central India that it is higher. Then we have also tried to see, this is a unique paper of GDM, neonatal and maternal outcome in women treated with diet versus insulin. Now a woman comes to you in a clinic, you have to decide, whether this woman is likely to be managed only on diet. GDM women, 70% are going to be doing well with medical nutrition therapy. Only 30% going to need pharmacotherapy. So whether the woman will need insulin or diet, how to choose that. So we have this paper comparing almost 800 women in this cohort. Women receiving insulin had a low risk of preterm, low birth weight and macrosomia. Contrary to our belief that we are over-diagnosing and over-treating, that may not be true in our country. If you judiciously diagnose and treat GDM, the risk and give insulin therapy, the preterm delivery, low birth weight and macrosomia is less versus in those who are only on MNT. Neonatal hypoglycemia was higher because most of them were on insulin therapy. 2 hour, this is important, 2 hour glucose tolerance test, more than 163 milligram and or fasting more than 90 are likely to need insulin therapy. Individual with the propensity score of 0.7, more than 0.7, which I'll tell you later, will require insulin therapy more. A study also revealed that individual with bad obstetric history, positive family history of diabetes, obesity, elevated fasting, blood glucose, 2 hour and GHB will be requiring higher doses, and this might help you treating the patient properly. Neonatal hypoglycemia was found to be higher in the insulin treated group. So what we have done is, we have used the propensity score matching to stratify the group. So we have initial full dose of initial dose of insulin and the full term dose of insulin per kg body weight, and we have divided into 4 different quartiles. And these 4 quartiles on the basis of these various risk factors which I told you, and this is called as log plot. So once you match these groups properly, then you come with this log plot, which again is rare to know. I heard it for the first time. So we considered age of the mother, parity, BOH, family history of diabetes, pre-pregnancy BMI, HbA1c, fasting, and 2 hour blood glucose. And we found that the first 3 group, first to third group, is absolutely same requirement of insulin. Almost, if you see initial requirement around 10 units, 9.4, 9.8, 11, and at the time of delivery almost 19, 19, 17. But the 4th group, which has higher risk factors, is requiring almost 30% higher dose in the beginning as well as at the time of delivery. So this is another message that I told you, more than 163 post glucose and or the more than 90 fasting might require insulin therapy, and those who have higher risk factor will require higher doses versus the first 3 groups. And if you see the number of patients, almost 9,500 in all 4 groups. And this again the risk factor which I told you, which will guide us. So insulin doses, if you just combine GGI, GDM, type 2 diabetes and pre-gestational type 1 diabetes, pre-pregnancy weight, GGI will require around 0.1 unit per kg body weight, GDM 0.25 and pre-GDM type 2 0.5 and type 1 0.85, and it will go up to almost 1.5 times at the time of delivery. Insulin in twin pregnancy. There was one paper which has come from US, and this paper has actually shown that type 1 diabetes twin pregnancy required double the dose than the singleton pregnancy. And myself and Dr. Sanjay Gupta from Pune did not realize that. We said, we have not seen in our pregnancy, let's compile our data and see. So data of around 40-45 pregnancies, and what we have seen, GDM women with twin pregnancy or singleton gestation differed insignificantly in their treatment strategies and insulin doses. Insulin requirement need not be proportionate to the number of fetuses. So if you have twin pregnancy or a triplets, does not mean that it will require double or triple the dose of insulin versus the singleton pregnancy. So you should not be carried away with these papers. CGM use can be used authentically as per the concept data that it can be used for type 1 diabetes, but even in type 2 diabetes, most of the expert group have recommended can be used. Even in GDM it can be used. Application of CGM, this is the recent data recommendation, which application of CGM and automated insulin delivery technology in type 1, type 2 and GDM can be used in cases. GLP-1 analog is in use. Now most of us are learning this particular drug more and more, and now it is a pregnancy. Every meeting I go and we are being exposed to this question whether it can be given in pregnancy. So many of the obese women who have infertility as an issue or a polycystic ovarian disease, such patients are being given by the infertility clinics GLP-1 analog for obesity. And once they use this drug, they lose their weight and ultimately they become more fertile. That's the data which is showing. But whether this drug can be continued in pregnancy or not. So we have some data, GLP analog as a risk of congenital malformation. So there is no such concern at this moment of time when it's used. Around 938 pregnancies, as per the rate of accidental pregnancies already on GLP-1 analog, exposed to GLP-1 analog in the first trimester. So almost this 938 pregnancy, there was no data on the maternal glucose control, no data of stillbirth, abortion, and there is no increased risk of congenital malformation. They are accidental pregnancies already taking GLP-1 analog. So the final message from this paper says there is no study examining the pre-conceptual use of GLP-1 analog for the maternal hyperglycemia. More studies are needed. At this moment, it is contraindicated pregnancy. If you are using semaglutide, you should withdraw this drug 2 months prior to planning the pregnancy. And if you are using tirzepatide, you should be withdrawing it 1 month prior to the planning the pregnancy. Postpartum follow-up is at most important. Breastfeeding should be encouraged, and these women who have GDM who become normal need to be followed again for prevention and for prevention strategies for developing diabetes. The final answer, of course, is mass awareness, and education is the most powerful weapon which you can use to change the world, and COVID has taught us that it really works, and that's why you have National GDM Day, the 10th of March, the birthday of Professor Shaiya, which is being recognized as National GDM Day. And India is the only country where you have National GDM Day. So we, during my presidentship of DIPSI, we started a public awareness initiative called as Prega Talk. And we have 22 languages in the Constitution of India. And we have done this program first cycle in all 22 languages, second cycle, third cycle. And this March in 2026, we have inaugurated the fourth cycle during DIPSI on 8th of March. And the first part, because DIPSI has come from Tamil Nadu, so always we make it a point that the fourth cycle, the first meeting, and that is the 74th episode of Prega Talk, has been started with Tamil, which already we have done it on the 3rd of April, and next we'll be doing Gujarati on the 3rd. So first and third Friday, and I appeal here everyone that those who really want to take interest in this public awareness Prega Talk program, which is online program, which is on first and third Friday of every month, I'll be happy to involve you people in the Prega Talk in Bengali language also. So this Prega Talk is very much popular now. This is the fourth cycle which was inaugurated, and we have got an appreciation letter from both Devendra Fadnavis ji, who is the Chief Minister, and Nitin Gadkari ji for this public awareness initiative. We were also felicitated for the Prega Talk by Dr. Jitendra Singh in 2025 DIPSI. And this is again through various programs like All India Radio and podcast. We are doing this program, and All India program is live phone-in program. It's again a unique program, and I'm very serious on this issue that we should be involving more into public awareness through various forums. We have also doing a weekly article now. CCGDM is one thing. I'm a part of this course since its inception, and it's still doing it by training OBGYs as well as physician. And this is a recent concept we have done, that why not you give fitness for cataract surgery, you give fitness for hernia surgery, why not to now start a concept of fitness for pregnancies, those who are known type 1 and type 2 diabetes. So preconception counseling care has to be stressed upon through education, and fitness for pregnancy, every clinician should now give this to the women by assessing all the parameters, blood glucose, drugs, and the glycemic control, and make them fit for pregnancy. If the glycemic control can be maximized to the extent that the fetus no longer recognizes that the mother is diabetes, then the treatment of mother during pregnancy may become the first step in the prevention of obesity and diabetes in the offspring. And this primordial prevention is, if you want to save our country from getting more and more newer cases of type 2 diabetes, possibly we'll have to focus on pregnancy. So focus on the fetus for the future is a mantra from Professor Shaiya. We all follow that. And before I stop, thank you very much once again. Cut the fruit and not the cake. This is another mantra we want to give. Instead of cutting your cakes and cookies and pastries which have high hydrogenated fat, if you start cutting watermelon, if you start cutting pineapple or papaya and celebrate any occasion, that can be another good message to the society as a whole. With this, I stop here. Thank you very much for patience listening.
Since this is an oration, we will not take any question answers on this. Maybe I ask everybody to give us standing ovation to Sir.
Thank you very much. Thank you very much. Thank you. I'm honored.
Thank you, Chairpersons. And we now move forward. Thank you very much, sir, Dr. Sunil Gupta, sir, for an excellent deliberation. And we are really honored to have you here. So moving forward, we now have the state-of-the-art lectures. And for that session, I would like to call Dr. Anirban Ghosh, Dr. Ashish Basu, and Dr. Arun Virmani, sir, as the chairpersons. And a little change in the schedule, I would also request the chairpersons to kindly invite Dr. Arun Raghavan first for his session, because it just got delayed. So the first speaker would be Dr. Arun Raghavan, and then the state-of-the-art lectures by Dr. N.K. Singh sir and Dr. B.M. Makkar sir.
Dr. Arun Raghavan is a director, consultant diabetologist and metabolic physician at Revivo Clinic, and he is here to present on his topic on GLP-1 receptor agonists and SGLT2 inhibitors in perioperative setting, whether to use it or not. Over to you.
Check. Thank you so much for the introduction. It is indeed an honor and pleasure to be here at AMOCE-EMOCON 2026. Also my greetings to Professor A. Ramachandran, who's been my mentor as well as my father figure, and respect to all the other senior faculty members here. So the topic that I'm going to talk about today is the use of SGLT2 inhibitors and GLP-1 receptor agonists in a perioperative setting. So all of you would agree with me, it's no better time to talk about this because the market is flooded with semaglutide, isn't it? So it's likely that many of our patients are going to be taking GLP-1. And I would also presume that most of our patients are either on GLP-1 receptor agonist or on SGLT2 inhibitors, isn't it? Right? I know these molecules are even licensed to be used even in conditions other than diabetes. So it is imperative that we know how to handle these drugs so that we can guide our surgical colleagues as well as anesthetists so that the patients can have a very smooth outcome during their surgical period. Now, the data as we have right now is still evolving. Much of the data has come from case reports, case series. So there is no robust RCTs yet, but much of it is consensus driven and some from certain small RCTs. That's why you see a little bit of conflicting recommendations here. The FDA suggests that you stop SGLT2 inhibitors 3 days prior and etugliflozin, because of its longer action, 4 days prior, right? Whereas the Center for Perioperative Care says that stop SGLT2 inhibitors just on the day of the surgery, a more pragmatic option. Whereas with GLP-1 receptor agonists, the once daily, the FDA says stop on the day of the surgery, whereas the weekly ones GLP-1 receptor agonists stop 1 week prior to the surgery. Contrastingly, the Center for Perioperative Care says continue the use of GLP-1 receptor agonists even if the patient is planning a surgery, right? And all of this is elective surgeries, remember, not emergency surgeries where we don't have any control of. All these are scheduled elective surgeries. Now let's dive in a little deeper. GLP-1 receptor agonists, what do? They have glucose-dependent insulin release, so stable blood glucose environment. So the disadvantage probably would be delayed gastric emptying, right? All of us know that. So suppose a patient is, you stop the GLP-1 agonist, is okay, but if you continue the GLP-1 receptor agonist, what happens is even if the patient is fasting, the next day he could still have some residual gastric content, right? That could be challenging during anesthesia, higher risk of aspiration, and also post-operative nausea, vomiting, right? These could be challenges. So how do we overcome if you are continuing GLP-1 agonists? We'll see that in the subsequent slides. SGLT2 inhibitors, pretty explicit, quite explicit. Recommendations are consistent. You stop the SGLT2 inhibitors because of the risk of diabetic ketoacidosis. We know that concomitant infections, radiocontrast studies, surgical periods, all of these times we have to stop the gliflozins. Now, it is not just for patients with diabetes. There are also reports that even patients without diabetes are prone for ketoacidosis. Now, the term there is euglycemic ketoacidosis, not euglycemic diabetic ketoacidosis in patients without diabetes. So let's look at GLP-1 a little more closely. So let me show you two scenarios. So you stop the drug, you miss the drug, what happens? Now you need to fill in with some insulin or something, right? And then you ought to watch out for hypoglycemia, right? So you have to go back and forth. Now we know what happens when you miss GLP-1 receptor agonist, then you'll have to start all over again, initiate, suppose a patient is on 1.7 milligram of semaglutide or a 7.5 milligram of tirzepatide, you'll have to start all over again, overcome this nausea, vomiting, so on and so forth, right? Whereas if you continue GLP-1, you continue that stable glucose environment, right? But what are the challenges? You have to be very, very vigilant. You have to assess the risk so that patient has a smooth perioperative period. We look at that also in the subsequent slide, right? Now, the American Association of Anesthesiologists say that you have to stop the GLP-1 a week prior, right? But what happens, suppose 1 milligram, patient is on 1 milligram, you're withholding the drug 1 week prior, still there is plasma concentrations of 0.5 milligram, right? That's a challenge, right? So think about a patient who's on 1.7 milligram, about 0.85, right? So this patient is still likely to have some plasma concentration, so which makes this recommendation a less logical, right? That is why you see the Center for Perioperative Care suggesting that you continue the use of GLP-1 receptor agonists as per the data that we have now. So how do we be vigilant with patients who are planning surgeries? Now, first is pretty easy, gastric ultrasound bedside just before the surgery, assess the gastric contents. That is a very pragmatic approach. And then prefer regional anesthesia over general anesthesia wherever possible. And if general anesthesia is the only way forward, use tracheal intubation because you can inflate the cough, you can prevent aspiration. Whereas if you use the laryngeal mask or other methods, you won't be able to seal the trachea. So the risk of aspiration is high. Now this is something that you'll have to discuss with the anesthetist, right? If the patient you're continuing GLP-1, it is important that you discuss with your anesthetist colleagues and discuss about the option of intubation. Employ modified rapid sequence induction, meaning you'll have to sedate the patient, paralyze the patient, don't use any ambibag, immediately you'll have to intubate, right? So you don't create a window period where there is a risk of aspiration. And then when you're planning extubation in an alert, conscious patient, again, so that you don't have any risk of aspiration. Now, looking at SGLT2 inhibitors, like I said, quite explicit, there's no doubt. You'll have to stop because the continuing SGLT2 inhibitors, what it does is knocks out the glucose out of the urine, so there is less glucose, so there's less trigger of insulin. And during surgical period, whenever there is excess stress, there's a counter-regulatory surge, which can predispose to increase in ketones. So that is why it is recommended to be withheld. However, the Center for Perioperative Care argues, why do you withhold the drug 3 to 4 days prior? Because you may deny the benefit of continuous glucose control with SGLT2 inhibitors, and particularly in patients with systolic dysfunction, we know that even 2 to 3 days of denying that could create a hemodynamic disturbance, right? Because that's the value that SGLT2 inhibitors bring to the table. So it's about 3 days versus 1 day, probably in patients who are minor procedures, etc. You could stop on the day, whereas high-risk procedures prone for ketosis, maybe we can consider stopping 3 days before. So finally, to conclude with the available literature that we have, at this point in time, GLP-1 receptor agonists can be continued, but as I showed you in my presentation, assess the risk, be vigilant, and make sure you discuss with your anesthetist colleagues, surgeons, and see the options. Whereas SGLT2 inhibitors, as I mentioned, minor surgeries, possibly you can withhold on the day of the surgeries, whereas major surgeries, etc., high-risk cases, you may opt to withhold 3 days prior. With this, I'd like to conclude. Thank you so much for the organizing team, to give me the opportunity. Thank you.
The audience is now requested to ask questions, if any.
If there are no questions, we'll go to the next speaker.
So our next speaker is none other than Dr. N.K. Singh. Dr. N.K. Singh will take us through the insulin-resistant revisited contemporary insights into an age-old metabolic challenge. It's a very exciting topic, and you know, Dr. N.K. Singh is a very renowned speaker, and is MD, FICP, and diabetes care physician based at Dhanbad. He is Director, Diabetes and Heart Research Center, Dhanbad, Executive Member, National RSSDI from 2022 to 2025, currently Vice President, RSSDI National, ex-governing body member, National API National, ex-chairman, API Jharkhand and chairman, RSSDI, author of several books and monograph and lots of publication in national international journals, founder of CME India WhatsApp group, editor-in-chief, www.cmeindia.in. So with this interaction, I call upon Dr. Singh to start his deliberation. Over to Dr. Singh.
Good afternoon. Thank you, Chairperson, for long bio, but anyway, I think I'm really thankful to Dr. Supratik and this great conference. He has given a bit different topic to me this time, that is the insulin resistance revisited. Everybody is aware that is an old concept, but what is the recent concept that we are going to discuss? You are well aware that the insulin resistance can be defined as a state where abnormally high levels of insulin are needed to produce a normal response in target tissue. It was 1960 it was identified, and using a new method to measure insulin, it was later found that individuals with late onset diabetes had elevated insulin levels. So this is how we started. Then the next breakthrough came when it was discovered that in rodents, high insulin levels due to insulin resistance were associated with abnormal insulin binding to its receptor. And it was 1976, it is not so late, it was 1976 that the first evidence that defects in the insulin receptor, so we came to the insulin receptor, that could lead to insulin resistance in humans, provided further confirmation of the significance of IR in human health. And you are well aware that in 1988, even proposed that this was the underlying factor in the modern concept of all the metabolic diseases. So this is really interesting. So from the 1993 of knowing about the TNF alpha production to 2003, a mechanistic era when the tissue-specific adipose tissue insulin resistance came in existence, and in 1994, the leptin discovery, and 2007, the macrophage polarization, and it was 220 that multi-omics and precision medicine started in play. This is really interesting. So what is happening that there is massive insulin input output that is forces glucose into cells, protecting against the hyperglycemia which is occurring, but also driving systemic hypertension and atherosclerosis. And ultimately the beta cell failure with the glucose toxicity and lipotoxicity exhausts the pancreas, so insulin secretion drops, failing to overcome resistance, resulting in clinical hyperglycemia. So this is what is happening. But why it is happening? So it is our lifestyle choices, the hormonal and the metabolic influences, and some of the hereditary factors that attenuate the biological response to insulin stimulation, leading to unrestrained glucose production and lipolysis in target tissues. So you can see that the physical inactivity, your diet, your sleep pattern, your hormonal and metabolic determinants, and genetic factors too. So these are very, very important players. You have seen that 25 to 40% you can have some insulin resistance heritability also, apart from the epigenetics and the non-coding RNAs are coming into play. So ultimately, now the concept is on the adipokines, that the fat tissue shifts from an endocrine organ secreting your protective adiponectin to releasing a pro-inflammatory cytokine. So this is happening. And then your gut microbiome dysbiosis in 2026 has come into a big play. How this insulin resistance cells is happening? This is due to the modifiable lifestyle factors, gut microbiome dysbiosis, and the adipose dysfunction. This is the recent concept. And then what is happening? There is a hidden phase. Remember, you are healthy today, then you are someone is developing type 2 diabetes, but in between there is a hidden phase. And this hidden phase is where the insulin resistance affects 20 to 40% of the population. It operates very silently, forcing pancreatic overproduction of insulin to maintain normal blood sugar. And remember, this is the missed window. So if you have some techniques, some ways to detect this hidden phase, you have an opportunity to prevent it or to halt it. So chronic insulin resistance is the primary precursor to type 2 diabetes and cardiovascular disease. And if you identify it early, you can reverse it by lifestyle modifications and other things. So there is definitely a long change here that they are from the traditional view of, this is the focus of glucose, your pancreas, muscles you are thinking, then later stage type 2 diabetes happening, and later you are developing some microvascular complications. But the emerging view is not this. Now the view is there is a clear-cut cardiometabolic brain axis with the insulin resistance. And the endothelial breakdown, atherosclerosis, and neurodegeneration also could occur due to this IR. So lots of things are happening. So remember that this first part of my talk is that there is a systemic breakage where the adipose tissue insulin resistance as the metabolic hub. So like this is a hub. Your hub of insulin resistance is adipose tissue here, where that leads to again type 2 diabetes, your NASH or cardiovascular disease, or polycystic ovary disease, or the obesity. If you seek it tackling the organ-specific damage, the strong evidence is with the type 2 diabetes or this NASH or NFLD, and there is moderate with the PCOS. And very recently, you can say the emerging thing is the cancer. There is a preliminary data that is saying that again the insulin resistance is responsible for this. I will show you some slides for that. So ultimately, this is very important slide where there is some dysregulated insulin release. So insulin release is dysregulated. Then there is some way there is peripheral insulin resistance, and ultimately this insulin resistance in the liver. So this is how the things are happening. And ultimately the major focus today is on the molecular mechanism of adipose tissue insulin resistance. And there is a long change of things. I'm not able to tell you the details, but you can say the key molecular players are what are, you can say that UPR, JNC, and so many things are there. But this is how from the normal adipose tissue, with all these mechanistic views which I am showing you, the insulin resistance is happening. Now, how you are going to diagnose the insulin resistance, that is a big problem. So I think this slide is important. You are well aware that the gold standard is again the hyperinsulinemic euglycemic clamp, but this is not for our daily clinical use. Insulin tolerance test or GTT, they also measure the systemic clearance. That is easy to perform, but if you do a ITT that carries significant risk of hypoglycemia and hypokalemia, so you have to go some for the surrogate markers like HOMA-IR and HOMA-2. Maybe HOMA-2 is more for research, but basic for clinical purpose, we can also go for the HOMA-IR. Other are quickie or other indexes are, I think, there utilizes some fasting triglycerides, HDL to identify lipid-driven IR. So I think still what I feel that the HOMA IR is still for the best for our clinical practice. But apart from that, if the patient has got some of the symptoms and you are going for evaluate the insulin resistance, there are two ways you have to see. One is you go for the methods of insulin resistance by the GTT, ITT or hyperinsulinic camp, I told you, and then the surrogate markers, I again showing you, you go for the HOMA IR, you see about the triglyceride, you see about the HDL cholesterol. And then there with these gaps, there is also one more thing has emerged, that is the METS-IR. And this has become highly practical, non-insulin based composite index, and this index serves as a superior real-world monitoring tool to track patient metabolic response to microbiota modulation. So I showed you that the microbiota modulation coming in the center. So if you want to tackle that or to know that, this index could be helpful. So ultimately there is detecting IR early is a very important problem, and lots of biomarkers are here. We can see here IL-6, TNF-alpha, adiponectin, RBP4, cysteine, and so many things. Also, you can do some neuroimaging as a metabolic window. And this is a new thing which is coming up to know the insulin resistance. So neuroimaging, and then very recently, the Wear Me study came, which showed that even with your Apple Watch or a smartwatch, there is a study which is decoding the metabolic health, and it showed that you can predict HOMA IR by just your Apple Watch. So this is very recent, recent study which appeared. If you go for the only 3 minutes left, so pathological overview, just see there how this lipotoxicity from healthy signaling is going to the jammed lock. It is very complex, but see here how this healthy signaling to a IR signaling occurs. It is a huge mechanistic pathway. So it is just, if you are interested, you can go for that. But ultimately, this slide is important. Definitely there is evidence today that with insulin resistance, there is a cardio-metabolic and now the brain axis. With that, the M2 to M1 macrophage shift is happening. You can see how the healthy vasodilation to inflamed stiffened part is happening, and then leading to glucolipotoxicity derives a synchronized collapse of parenchymal organs. So this is happening. Now, ultimately, this the last slide from the second part, that there is a meta-inflammation concept, that this serves as a crucial link connecting the enlarged dysfunctional visceral adipose tissue with negative clinical consequences. And you can see how this meta-inflammation is occurring, that which I showed you. And the most recent part is the occurrence of the HCC, so carcinoma. And there is a clear-cut linkage emerging where the insulin resistance can ultimately lead to HCC. So this part is also very important. And so from the insulin resistance, you can see how things are happening to the liver, the brain, the ovaries, the vascular system. So last part is, I will deal in 2 minutes, what are the therapeutic strategy of insulin resistance. You see that treating a liver disease requires the network of the lifestyle adjustment, the weight management, and the tailored pharmacotherapy. And so from the step 1, you can see the low fiber, high fat diet intake. You can see the weight dependent effects you can have, the reduced hepatic fat accumulation, and these are all now possible due to many of the therapeutic agents. And the clinical goal is to restore the IRS, P13-KT signaling, and lowered HOMA IR and sustained glycemic control. And even this Mediterranean diet showed that there is a 31% risk reduction of the diabetes by just modulating the insulin resistance. So DASH diet, the low GI diet, plant-based diet, intermittent fasting, all have shown that this can reduce the development of this insulin resistance. Even there is some data with the ketogenic diets, low-carb diet. As you can see, the comparative matrix also you can see here with all of the interventions. But today, redefining the treatment paradigm, the endocrine blueprint is very, very important. And so there is role of now the prebiotics, probiotics, symbiotics, postbiotics, and some has some problems, some has some impacts, some has some key agents. So ultimately the most important part is the physical activity, the low glycemic diet, the microbiome modulation, the next generation targets, and you can see the evidence-wise, the lifestyle and this THD has established a development status is there. And if you see about the GLP-1 agonist, they have established, but multi-receptor agonist, they have phase 3 trials and unknown long-term safety not known. What about this THR beta agonist? The resmetirom, this is an indirect modulate that can also modulate indirectly the insulin resistance. This is not going to, this is not an insulin sensitizer, but this can modulate also. So this is also important. So you can see ultimately this part I showed you, and the last slide is here, the translational agenda, the mapping the future metabolic medicine is happening today, and with this, my final points are that the emerging therapies are very, very exciting. I think this is a very, very important issue that we are going to deal in the next few years. Thank you very much, sir.
Thank you, Dr. Singh, for a very exciting and innovative, informative, illuminating deliberation. And you have enriched our knowledge about the current upcoming views on insulin resistance. So insulin resistance ultimately is also one of the pointer towards the hepatocellular carcinoma, and the microbiome modulation is a new exciting pathway to take care of this insulin resistance. So wonderful lecture. Now his lecture is open for interaction from the August House gathering. Any questions? So if there is no question, once again we thanks a lot. A big round of applause for Dr. Singh.
Thank you. Next speaker is Dr. B.M. Makkar from Delhi. He is the chair IDP Obesity Task Force, president of IRO, past president of RSSDI, and has got a huge number of orations and publications. He will be talking on liver in the driver's seat, metabolic control of the disease. Over to you, Dr. Makkar.
Thank you, sir, for those kind words. Good morning, everyone, or just became afternoon. So first, at the outset, I would like to thank the team of AMOCE, especially Pratik and Meenal, for giving this opportunity for this topic, and also thank Kanchan for giving me an interesting topic, which is liver in driver's seat, metabolic control of the disease. I don't have any financial disclosures for this presentation, and in this presentation I'm going to use all the terms MAFLD, MASLD, NAFLD synonymously, because I will be quoting studies at different stages of classification, and these terms have been used earlier. So first thing we have to understand is that liver is a key metabolic organ in the body, serves as a central metabolic hub orchestrating body's response to nutrient intake and storage. This is also the first organ which gets the nutrient-rich blood from gut and is involved in the metabolism of carbs, protein and fat. It also has the unique ability to channelize different substrates into different metabolic pathways when it is coordinating with the mitochondrial activity and controlling the flexibility of metabolism. Now we all know MASLD is defined as a disorder which is characterized by excess fat in the liver due to non-alcoholic causes. And metabolic syndrome is a cluster of metabolic abnormalities that identifies people at risk of type 2 diabetes and cardiovascular disease. Now, important thing to keep in mind here is that there are two components of metabolic syndrome, glucose and triglycerides, which are overproduced by fatty liver, and fatty liver also plays important role in causation of metabolic syndrome. Now, there are several genetic variants where there is an increased risk of getting NAFLD, but these variants may not be necessarily associated with the components of metabolic syndrome or insulin resistance, and that is why we will not be keeping them in discussion here. Now, we all know that lifestyle, specifically the high calorie intake, the excess saturated fat intake, physical inactivity and so on, are associated with both obesity and NAFLD, and obesity leads to increased prevalence of both MASLD as well as metabolic syndrome. Metabolic syndrome and MASLD both predict the increased risk for type 2 diabetes, cardiovascular disease, MASH and hepatocellular carcinoma. Now, if you look at the established risk factors for NAFLD, these include obesity, type 2 diabetes, dyslipidemia and metabolic syndrome. But important thing to keep in mind is the components of metabolic syndrome drive the development of MAFLD. This is the understanding that we all the time are carrying with us. Another thing that now we have evidence for is that there is evidence that MAFLD also contributes to increased risk of developing type 2 diabetes and cardiovascular disease. So let us look at NAFLD as predictor of other diseases. NAFLD predicts type 2 diabetes, and there are a number of ultrasound diagnosed NAFLD studies which have shown that type 2 diabetes has independent predictor as NAFLD. Some of these studies have suggested that NAFLD predicts type 2 diabetes even independent of all the components of metabolic syndrome, and suggests that NAFLD may be a better predictor of type 2 diabetes risk than metabolic syndrome. NAFLD also predicts cardiovascular disease. NAFLD predicts CVD even when adjusted for obesity. The underlying mechanism is unclear, but might partly be because of the many risk factors which are affected by fatty liver, such as high glucose, high TG, low HDL, increase in small dense LDL levels. These metabolic changes in liver could be primary or secondary to the consequence of insulin resistance in other tissues and the adipose tissue and skeletal muscle. Looking at the intricate relationship between NAFLD and cardiovascular disease, AHA came up with a position statement in 2022 stating that leading cause of mortality in people with NAFLD is cardiovascular disease, and therefore identification of NAFLD is important aspect in prevention of CVD. NAFLD is associated with visceral adiposity, atherogenic dyslipidemia, insulin resistance with or without hyperglycemia, and although a portion of risk of CVD complications from NAFLD is attributable to these comorbidities, a diagnosis of NAFLD is associated with greater risk than the sum of the risk offered by these individual components. NAFLD also increases the risk of thromboembolic complications. Liver, when it is fatty, overproduces several coagulation factors, especially the factor 7 to 9, factor 11, 12, and fibrinogen, and these contribute to risk of thromboembolism. NAFLD also increases the risk of gallstones by overproduction of cholesterol and displays other changes in cholesterol metabolism that contribute to formation of gallstones. And there are studies which have clearly shown that once there is NAFLD, there is increased risk of gallstones, and these gallstones presence is associated with advancing fibrosis and necroinflammatory activity in liver. Now, this diagram sums up everything that I have told you just now. Once there is obesity, there is increased central obesity, there is increase in the adipose tissue mass, there is increased production of free fatty acids, increased production of ceramides, adipocytokines, and decrease in adiponectin with engagement of macrophages and setting up of inflammation. This leads to increased lipolysis, increased production of free fatty acids which are entering the liver. In addition, there is dietary intake of sugars which is leading to de novo lipogenesis, and there is increased production of triglycerides and increased production of TG-rich VLDL. At the same time, because of insulin resistance due to fat in liver, there is increased production of glucose and leading to increased requirement for insulin, leading to hyperinsulinemia on one side. Once there is lipotoxicity, this ectopic fat goes and deposits in different organs, including pancreas, leading to decreased production of insulin due to beta cell dysfunction, again leading to increase in the glucose levels. On the other side, increased production of TGs leads to increased TGs in lower HDL levels and increase small dense LDL in circulation, leading to dyslipidemia, atherogenic dyslipidemia. So once there is overproduction of glucose, VLDL, C-reactive protein and so on, this leads to defect in the beta cell, leading to decrease insulin secretion. On the other hand, because of insulin resistance, there is increased demand for insulin, and this leads to development of diabetes. On the other hand, because of atherogenic dyslipidemia, there is increased risk of cardiovascular disease, there is procoagulant, pro-inflammatory state leading to deep vein thromboembolism, and there is formation of gallstones. Studies have clearly shown on the x-axis you will be seeing the liver fat. So as the liver fat increases, this is associated with central obesity, fasting glucose increase in triglycerides, lower levels of HDL, and increase in both systolic and diastolic blood pressure. So once there is obesity or adiposity, there is increased production of free fatty acids and inflammatory cytokines, decrease in adiponectin levels, and development of insulin resistance. And this leads to increase in the fat deposition in ectopic sites, including liver. Once there is increased ectopic deposition of fat in liver also starts producing inflammatory cytokines, worsening the inflammation in adipose tissue. And both these are contributing to development of myocardial steatosis on one side, renal steatosis on other side, increased insulin resistance, decreased beta cell function, increased procoagulant, pro-inflammatory state, and increased production of free fatty acids, free radicals, leading to significant inflammation. Now, fatty liver leading to dysfunction at the renal level, leading to hypertension, chronic inflammation, hyperuricemia, leads to increased risk of atherosclerosis on one side. On the other side, this leads to increased risk of developing cirrhosis. Once there is development of fibrosis in liver, again this leads to secretion of vasoactive amines. Vasoactive amines lead to increase in atherosclerosis. So there is a bidirectional relationship between metabolic syndrome, type 2 diabetes and MASLD, which is which is a very strong bidirectional relationship, and they both lead to each other's worsening. Again, coming back to the same thing, increase intake of calories, increase in the free fatty acids in circulation, increase peripheral insulin resistance, as well as increase hepatic insulin resistance, leading to increased demand for insulin, decrease beta cell function, leading to development of type 2 diabetes. At the same time, atherogenic dyslipidemia and myocardial steatosis, leading to the cardiac damage. Liver also does, there is a lot of crosstalk between liver and other organs, and leads to unhealthy metabolic state. We also have to keep in mind that liver is the central site of lipoprotein metabolism, and this leads to this contributes to development of atherogenic dyslipidemia and a strong interaction between heart and liver also. Liver renal axis also mediates renal protection. So once there is fatty liver, this axis goes haywire. So liver produces hepatokines like phytoin A, adoptin, FST and RBP4, which have anti-inflammatory, anti-apoptosis properties and protect the renal function. But once there is renal dysfunction, this leads to increased uric acid, increased toxins, damaging the liver and changing the whole story of hepatokines, leading to damage. So liver secretes a series of proteins which into blood, which after circulation end up in kidney and protect kidney. They play an important role not only in protecting the kidney, but protecting, giving protection to people with nephropathy also. MASLD is also associated with cognitive dysfunction through multiple pathways, and also is important for liver function is also important for bone health. So hepatic osteodystrophy is a systemic metabolic disease which results from destruction of homeostasis in the liver-bone axis and leads to increased risk of osteoporosis. And we know myostenosis is common in people with metabolic syndrome and leads to increased a requirement for insulin, worsening the risk of diabetes. Liver also is the site where the blood is coming from gut, through portal circulation. So there is a lot of flux of gut microbiota which ends up in liver. And liver plays an important role in modulating the gut microbiota also and improving the inflammation. So to conclude my presentation, NAFLD closely resembles metabolic syndrome with regards to its causes and consequences. For these individuals, liver fat content is excellent marker of metabolic abnormalities causing metabolic syndrome. NAFLD predicts both type 2 diabetes and CVD, independent of metabolic syndrome, and may be a better predictor of type 2 diabetes and cardiovascular risk. The better prediction may be because of the liver fat provides a more direct measure of risk as compared to the total components of metabolic syndrome. The incidental finding of increased liver fat content due to NAFLD should lead to a careful evaluation of presence of other components of metabolic syndrome, and otherwise also people with metabolic syndrome should go for evaluation of MASLD. With that, I conclude my presentation. I would request all of you to block your dates for the forthcoming ACCD, which will be happening on 15th-16th August in New Delhi. Thank you.
Thank you, sir. You have very nicely highlighted the fact that liver is the seat of power as far as metabolic syndrome is concerned. And that is why the current proposal is there to rename CKM syndrome as cardiac kidney hepatorenal syndrome. And any questions from the House? It's open for discussion.
So everybody has understood everything.
Yeah.
Thank you, sir.
Thank you.
And any drugs can help in this case? Should we recommend any drug?
So the problem is we just jump onto drugs every time. Lifestyle interventions, we know what is causing metabolic syndrome. The major component is increased intake of sugars, not even fat, and decreased physical activity. That is the first correction. Of course, all the drugs coming from GLP-1 stable are effective in reducing weight and changing the trajectory of all these complications.
Now, Dr. Abhishek Arun will give lecture on transitions of care in hospitalized patients with diabetes. Dr. Abhishek Arun is a academic excellence. He has done MD, MRCP, FRCP, and also fellowship in CMC Vellore and Royal College of Physicians, and done diploma in endocrinology for University of Liverpool, UK, and he is also consultant diabetologist and metabolic physician at Secord Hospital Private Limited. He has clinical research head of MB Hospital and Research Center, Lucknow. He is also visiting faculty department of diabetes, endocrinology and metabolism, CMC Vellore. He is also joint secretary of RSSDI UP chapter and speaker at various state and national level conference, and he has more than 50 publications in index journals, and he is also investigators in over 200 clinical trials. Okay, start.
Thank you so much, chairpersons, and thank you again, Dr. Supratik and Dr. Anshan, for inviting me for this wonderful conference, EMOCON. And my topic is a bit tricky. It's basically the transition of care in hospitalized patients with diabetes. And this will be the roadmap of my presentation. I'll be touching on the epidemiology, the pre-discharge planning, the inpatient glycemic loads, which was already been discussed earlier, and the discharge process, the post-discharge follow-up, and talking about special population, multidisciplinary team efforts, technology, barriers, and of course, the takeaways. So just to start the presentations, we need to understand why this problem is serious, why almost 25 to 30% of the patients who are admitted are having diabetes in general. It can be more, as it can vary from one hospital settings to another. So they have problems with diabetes and hyperglycemia, and almost 20% of them, they have higher chances of readmission rates because of the unstructured diabetic discharge, or they've been not really followed up well. So almost 40% of them has been found to have medication errors at the care transitions, almost 3 times higher chance of length of the stay in the hospital with poor glycemic control. And there's a vicious cycle which sets up, starting with the poor discharge planning, from the medication errors in the gap and follow-up to the glycemic instability, readmission complications, of course chances getting enhanced, and of course the cycles tends to get repeated on and on. So we need to have a pre-discharge planning. So for that, we need to risk stratify our patients. There can be 3 categories of patients we talk about broadly. You can color code them, and there can be high risk, moderate, or the low risk patients based on the individual patient's profile. Those patients having high A1C, recurrent hypoglycemia, new insulin insertion during the admission, cognitive impairment, no confirmed follow-up before discharge, recent history of decay or HONG, and of course EGFR less than 30, they fall into the high risk categories, whereas those having A1C pretty much similar, between 7.5 to 9, they have been on oral or basal insulin, first time diabetic related hospitalization, suboptimal self-monitoring, they are having problems of caregivers, discharge to rehabilitation process, or the elderly patients, steroid therapy on EGFR between 30 to 45. Now the low risk ones will be having A1C less than 7.5, more stable regime, established outpatient diabetic team follow-up. They have good self-management skills, reliable home support, admission for non-diabetic condition, any complications of course related to that. They have normal renal and hepatic profile and good prior glycemic log compliance. So these are risk strategies, and of course we have to do the discharge medication risk consolidation, because comparing pre-admission versus in-hospital medication needs to be considered. We have to decide on whether to resume, adjust, or discontinue certain agents. You can deprescribe the sliding scale which has been inappropriate, bridge the convenient IV to subcutaneous regime before cessation, account for the renal hepatic changes, of course reconcile the non-diabetic drugs, check for the drug to drug interaction, and profile a written summary to the patients once they've been discharged. So there are transitions which are happening once the patient is critical to a non-critical stage, and of course once the patient has been planned to discharge. Once the patient is on IV insulin, he's been shifted to subcutaneous insulin. We usually keep a total daily dose and we split that into basal and bolus part. There can be overlap of 1 to 2 hours to avoid rebound hyperglycemia, and of course you have to recheck the blood sugars during that phase. Of course the problems comes in once you have steroid induced hyperglycemia. Of course NPH insulin timed the steroid dosing is usually preferred, anticipated tapering the steroids, continuous SMBGs is very important, and educating patient about nocturnal hypoglycemia, and of course dexamethasone predominantly post-lunch glucose spikes are there. So that needs to be taken into account. And then of course before the pre-discharge we have to look at what are the insulin or the oral agents which have been prescribed to the patients. You need to tell the patients about the new device, the training of these devices, tell them about the CGM and SMBG. Medical nutritional therapy is very important. They have to tell about the carb counting, the portion size, the carbohydrate consistency, the glycemic index, of course, and of course the alcohol guidance, hypoglycemia management, sick day rules, and of course the red flag signs, of course, needs to be also mentioned in majority of the patients. Inpatient glycemic management is basically the target. These are the targets again talked about. The RSDI guidelines are pretty much similar to that. It's been again discussed by a previous speaker. So of course the ward insulin protocols are pretty much easy. They have already been discussed. So the discharge process, the one which I'll be talking about, we'll be again talking about the SBAR framework. We talk about the situation, background, assessment, and the recommendations. So the situation, of course, whether the patient is type 1 diabetic or type 2 diabetic, duration of the diabetes, current admission reasons, of course the A1C profile, the blood glucose values, of course, and of course the background which the patient has been presented in hospital, glucose trends, hypoglycemic episodes, medication changes, investigations, of course assessing the glycemic status as discharged, complications identified, and recommendations, what can be done for the patients in the follow-up visit, when that visit needs to be planned on. So components will be on clinical data which we have gathered from the patients during the hospitalization. We need to alter the drugs based on that and take an appropriate action plan based on the sugar levels, the target which we need to achieve for the particular patients. Of course, these patients can be different from one another. We have already talked about the risk categorization of them. Once we've been switching them and these patients on discharge, all insulin pens and cartridges needs to be checked in, glucometers, test strips, the sharp containers, glucagon or the hypo tablets needs to be told to the patient. Written medication summary, that can be a very useful tool once the patient's been discharged. Sick day rules and emergency numbers needs to be told to the patients so that they have a continuity of care during or after the discharge as well. Dietary handout can be very useful, especially in the regional languages. Follow-up appointment confirmation slip is useful because they know when to attend to the doctor is available or not. So of course, the prescription considerations needs to be ensuring that what kind of drugs they are taking, and they need to have a thorough supply of that, especially if they're taking insulin. Of course, the common errors can be continuing the hospital sliding scale or the drugs which have been given to the patients during the hospitalization, omitting discharge pre-admissions, like SGLT2 inhibitors or GLP-1 analogs sometimes, failure to stop metformin if the eGFR is declined, incorrect insulin concentration, no glucagon prescribed for insulin-dependent patients to take care of the hypoglycemia. So the post-discharge follow-ups, timelines can vary and it requires a lot of team effort as well. So there are different roles which are played by nurse, the general physician of course, the DSN clinic, the endocrinology or the diabetology review, and the glycemic goal review. They are different timelines for that, and they need to be followed up on different occasions. Once the patient's been more stabilized, they need to be followed up for the medical adjustment, reinforce their education, their dietary compliance, injection techniques. We do have to look for the overall A1C result, full regime review, complication screening from time to time, and then based on the individual values, you can set the targets. You need to intensify or simplify, and of course, review them in a timely manner based on those values. So post-discharge glycemic targets are also based on different categories of the patients. You have patients with type 2 diabetes with normal lifestyle. They can be having a good target of less than 6.5. Pregnancy pre-existing diabetes around 6 or 6.5. Type 1 diabetes on a continuous subcutaneous insulin infusion or the CGM around 6.5 to 7. Again, those patients who have recurrent hypoglycemia, now they are having more relaxed A1C targets around 8.5 to 8. Elderly frail patients again 7 to 8, and more non-pregnant adults less than 7. So these are the targets that need to be individualized, and the agents which you've been using should be targeted to prevent hypoglycemia, of course. So outpatient insulin titration is more simple. You already understand about the basal insulin. You need to start at dose of 0.1 to 0.2 units. Usually these doses are much higher in the hospitalized patients, and they need to be adjusted every 3 days based on the fasting blood sugar values. The bolus titration can also be very easy if the patient is requiring a basal plus or basal bolus regimes. They can be easily titrated, and these patients need to be told about the frequency of the blood sugar monitoring. They can rely on the SMBG or CGM can also be taught to them if they are able to afford that as well. So special population does need a mention over here, because the transition in elderly patients and chronic disease and heart failure patient and other patients needs to be looked in differently. So elderly patients, the targets are different. They mostly have a very simple regime. Early recognition of the risk factor, assessing the fall risk. Of course, they have to be reconciled for the different kind of medications they've been taking, addressing the polypharmacy, and weekly follow-up with them with the diabetic educator or nurse can be very useful. Chronic kidney disease, you need to stop metformin, the eGFR less than 30, and reduce the dose if the eGFR falls then less than 45. You can use GLP-1 analogs and SGLT2 inhibitors, insulin of course, you have to take into account that the sulfonylureas dose needs to be tapered down, and you are using a second generation sulfonylureas. And of course, you have to also look for the potassium levels, look for the creatinine levels or the EGFR, and of course need to be targeted these patients with the constant follow-up based on the dietary guidelines as well. So those patients having heart failure, post-surgical diabetes and newly diagnosed diabetes, there are also different kinds of patients, and they needs to be told differently about the different agents as well. So like in heart failure, you need to avoid thiazolidinediones. Of course, allogliptin and saxagliptin is also associated with the heart failure hospitalization. So again, a word of caution regarding that. GLP-1 analog, especially semaglutide, is preferred, and they need to be again told for the weight and the fluid status and dyspnea post-discharge. And post-surgical diabetes, again, they need to be told about the target of the blood sugars, continuing the basal insulin. You have to remeasure the blood sugars. Also look for the other agents, whether they are using other agents like SGLT2 inhibitors. So they preferably need to stop them in the post-operative period. They can restart it probably after 42 to 72 hours if there is no risk of decay or euglycemic diabetic ketoacidosis. Of course, they need to be again followed up, and the surgical clearance again needs to be taken before the final prescription needs to be tapered for them. Newly diagnosed diabetes again need to be taken differently. They need to be screened for complications. They need to be followed up again 2 to 4 weeks with A1C, and of course the kind of medication they have been on, they need to be again taken into account. So multidisciplinary team effort is a very important one. So the role of diabetic educator, diabetologist, endocrinologist, clinical pharmacist, dietitian, and the primary GP is a very important one, especially when the patient is coming from very remote areas. They need to be taken into account that all in all, the multidisciplinary team plays a very critical role in preventing complications post-discharge. With the help of technology and innovations, we have CGMs which can be very useful in even the post-discharge phase. The telehealth and remote monitoring are very useful tools, especially for the patients who are coming from remote areas. Clinical decision AI tools are also very useful based on the risk scores, which can ease out things for the patient and help in risk prediction. So the barriers, if you talk about the barriers, are poor health literacy, medication unaffordability, no confirmed follow-up on appointment, regime complexity, fragmented communication, hypoglycemia, overcorrection, inadequate diabetic education, and patient, of course, denying on follow-up. They need to be taken into account, and they need to be solved based on the evidence-based solutions. That's what we have pointed out, based on the motivational interviewing, of course, dedicated inpatient diabetic education services, a written chart to them, and the core role of the diabetic educator, diabetologist, giving them a tech-backed method, pictorial discharge instructions, culturally adapted material in local languages, which can really solve things to a great extent. So outcomes of such structures have led to a great amount of reduction in the readmission rates, decline in the incidence of hypoglycemia, improvement in overall A1C, and also improvement in the length of the stay. So just to summarize, the 10-point diabetic transition of the checklist is basically reconciling all diabetic medications, set individualized glycemic targets as per the patient need, self-patients, verify patients can demonstrate correct insulin technique, supplying the glucometer, strips, lancets, providing written hypoglycemia action plan, arrange a 24 to 40 hours follow-up, GP appointments in case of remote settings, a very useful post-discharge follow-up, notes to them, provide a sick day rules and document communication in full day summary once they've been discharged. So transforming discharge from event to continuum of care can be very important, and with the use of technology and the guidelines which we have, we can simplify it to the greatest extent. With this, I would like to conclude, and I welcome any questions if there are any. Thank you.
Thank you, Dr. Obise Korun. He has nicely delivered a very difficult topic, that is we have to face day-to-day practice in different difficult situations. Now we are also at time out. So if there is any questions from audience, just 1 or 2 questions can be given. Okay. If there is no questions, conclude the sessions. Okay.
Good afternoon. And now let's move forward to a very interesting session. I've been waiting for it also myself. And it is the Metabolic Adalat, and we have few molecules. We have expert jury, judge, and the prosecution and defense among us. And we have the Nyayamurthy ma'am has not come, but we have the judge here, Dr. Manoj Chawla as well. So I would like to invite our judge, Dr. B.M. Makkar. Sir is the director of Dr. Makkar's Diabetes and Obesity Center, New Delhi. Our expert, Dr. A.K. Singh, sir. He's a senior consultant and endocrinologist at GD Hospital and Diabetes Institute, Kolkata. Our jury, Dr. Meenal ma'am. She's consultant and head, Department of Endocrinology, Jaipur. And Dr. Prashant Shankar. He's consultant in internal medicine, MGM Muthoot Hospital. And for the first Metabolic Adalat, we have, just give me a minute. The first trial is pioglitazone, and for the defense we have Dr. Hridish Narayan Chakravarti. I would like the judges to kindly introduce him.
So, it's a very interesting session, and we are going to have 3 debates in this particular session. First one is going to be on pioglitazone, and to do this we have 2 eminent persons. One is Dr. Hridish Narayan Chakravarti from Kolkata itself. He is going to defend pioglitazone, and Rupam Chaudhary from Guwahati will be speaking against. And we have a structure here. Dr. Anchin just introduced. I happen to be judge, so I will be doing the final word with the guidance of expert. And we have 2 jury members. Actually, jury always has to be, odd number, so that if there is a vote, you have some side. So I would request my expert to be on jury side also as well as the expert. So he will do the dual role. So we can start with this. So I would request Dr. Hridish Narayan to start and present his case in defense of pioglitazone. And you have 8 minutes to go. The timer should be set on 8 minutes. 8 minutes.
Okay. So good afternoon, everybody. Thanks to EMOCON for inviting me. It's an excellent afternoon, and always it's good to talk on a debate side. I feel more relaxed when I'm giving a debate rather than when it's a talk. I get more tensed when I'm giving a talk. So thank you, jury. I will just try to impress upon the fact that this molecule is still relevant, and because this topic has been given, obviously sets the tone that at least something good is still there behind, so that we have not put it into the waste paper basket. So there is no conflict of interest, so obviously I have liberty of thought as well as liberty of expression. So आजकल जनाब इंडिया में क्या चल रहा है? फॉग चल रहा है? No, धुरंधर चल रहा है. So obviously when Hamza Ali Mazari was deported there, literally, to do some things, he faced a lot of hurdles. So obviously who frowns at my pioglitazone prescription? Cardiologist? नहीं, heart failure हो जाएगा. Nephrologist? नहीं, water retention हो जाएगा. Ophthalmologist? नहीं, macular edema हो जाएगा. Orthopedics? नहीं, fracture हो जाएगा. And my own resident, I can even convince him. He said, sir, weight gain हो जाएगा. So there are issues which we have to actually cross to prove my point, like Hamza Ali Mazari. Now, opening statement for this debate, my respected jury, obviously old doesn't mean obsolete. Mechanism matters more than fashion. Insulin resistance cannot be ignored in type 2 diabetes treatment, and a cheap drug with multi-organ benefit deserves scientific respect. I'll give you 9 arguments, 3 analogies, and 1 conclusion. So I have to rush through the slides because I have 70 slides, almost 7 per minute. Argument 1, and my point here is the pathophysiology advantage. So I start with analogy, lock and key. This house is the cell, the glucose is the person who is wanting to enter the cell, there is a lock which is rusty and jammed. So insulin cannot work. So I just put a spray of pioglitazone on it. Obviously this is AI generated without any copyright. And this actually smoothens the thing like a locksmith, and I could actually circumvent or alleviate or mitigate that insulin resistance to some extent. So obviously it improves the insulin sensitivity, hepatic insulin sensitivity, adipocyte redistribution, which I will touch upon in my next slide, and free fatty acid reduction. So obviously it has a lot of advantages. So it targets the root insulin resistance, unlike many drugs that mainly force insulin secretion. Argument 2. Efficacious and durable glycemic control. Now tell me who in this room has not seen this slide or this graph? Obviously we have all seen this, that out of sulfonylureas, metformin, DPP-4s, SGLT2s, which actually last the most? Obviously the TZDs, about 6 to 8 years if we go by research. I just quoted one article in the top. Even in the proactive study, they were showing that was a drop of 0.8% of HbA1c at the end of 3-year study with the predicted durability, if you extrapolate, to 6 years. Coming to potency and efficacy, I quoted this from Richard Hall's book, The Pickup, which was called earlier. The TZDs cause a HbA1c reduction to the tune of 0.5 to 1.5%. This is quite good. So monotherapy, be it in combination, is just like a liquid. You can combine with anybody. Obviously, if you combine with insulin, the weight gain may be more, the fluid retention may be more, but still, in some patients we are using, we can actually bring down the requirement of insulin. So proof of the pudding lies in the eating, and that is reflected in the guidelines. If you see nowadays, this is a recent guideline 2026, you can see that still it is mentioned that additional glucose control is required. This is one of the molecules you can definitely ponder upon and write in the prescription. This is actually today's problem. Whenever you go to a hypermarket or supermarket, everyone is interested, free mein kya mil raha hai? You want to buy a toothpaste, you need a toothbrush. You want a soap, you need a loofah to rub your skin. So that's the problem. The entire attention goes to those fringe benefits. Nobody thinks of that center point which is important in diabetes control. So fringe benefits are taking the focus, whereas HbA1c lowering is going. What else will you do with an HbA1c of 9 and then you will say, I will give you CV protection, renal protection, endothelial protection. It doesn't help. So when you're playing a carom board, how you're using your resources? There is a central resource, that is sugar control, and the others are the peripheral or the fringe things. Obviously look into it, but look at it holistically. That's the problem. So when you're putting a cherry on the cake, please don't forget the cake. That's important. So many drugs have fancy fringe benefits, but fewer are simultaneously efficacious and preserve glycemic durability over the years. Coming to the most important point, which has actually now put back pioglitazone back in focus, is the MASH. And because time is short, I will just glide through. There are some studies which I put temporarily. This is 2006, where I showed that balloon degeneration and all these things transaminitis can be brought down. This was in 2016. Obviously, at those times, some higher doses was used, even 30 to 45, which is now not used. This was in about 2021, and this was 2023. Ultimately, what happens is, when you again use pioglitazone, there is a lot of benefits, and if you see the 2026 guidelines, I'm happy to see that is placed at the same pedestal as GLP-1. I couldn't believe this. Just look at the algorithm AA 2026. Here it is, GLP, pioglitazone. Look at ACE, pioglitazone, GLP-1. So now it has won back its position. See, one of the rare anti-diabetic drugs that improves both pancreas and liver biology. Proven cardiovascular benefit, nothing much to mention. Proactive trial, we have already seen that it reduces all-cause mortality, non-fatal MI, stroke in patients. Beta cell preservation, obviously, this ACT NOW trial, which was done by Dufranzo, there's 72% reduction in the development of diabetes was noted. Also, there were some secondary benefits which I put here. Argument 6, cost advantage, everybody knows, affordable, widely available, practical long-term use. Argument 7, stroke prevention. I must mention IRIS trial. If you look at the curves, they start to separate, and you can see the cumulative probability of event-free survival was much more with pioglitazone. Argument 8, hypos prevention. Obviously, this is one of the classes of drugs that do not cause hypoglycemia. Coming to weight gain, the good weight gain. Some people say there are no distinction between good terrorists and bad terrorists, which we hear in politics. But here, weight gain can definitely vary. The greater the weight gain, the greater the HbA1c. I just took shelter with D. Franco's article because I'm always debated when I put this on slide. No, how can this be? Weight gain was associated with increased survival in the proactive study. That's why I put this slide here. Now coming to the second analogy, the financial audit analogy. People just take bad loans, the bank suffers, and they flee from the country. So what happens? This is actually what is happening in the system. Insulin resistance is the bad loan. Now comes a good female, strong, stringent and strict financial advisor. What she does? She rebalances, restructures the debt. What she does? She puts something into savings, and the entire company, instead of going to absolvency, is becoming solvent again. That is exactly what pioglitazone is doing.
Last 1 minute. Last 1 minute.
Yeah, okay. It's shunting the bad lipid to the good lipid. That's why the weight gain little bit happens. This stigma has largely been cleared, the bladder controversy, bladder cancer controversy. And you can go through the periscope trials and all these things as well. So lastly, I come to the end of the presentation saying there are some green light areas where you can use. History of stroke, TIA, biopsy proven MASH, severe insulin resistance, obviously. But do not give in red light zones where you should be cautious that these may land up you in problems. So long-term investment analogy is that unlike a short-term, the high interest loan, the immediate cash can be reckless, but invest in something that will give you returns. My last slide will be that a conclusion is you should filter the noise, you should respect the risk, and leverage the synergy. If required, you combine with a good agent like HLD2 and GLP-1. With that, I will say it is a closing statement. I will defend pioglitazone. Thank you. I rest my case.
So that was Dr. Hitesh Narayan, and now we have Dr. Rupam Chaudhary from Guwahati.
Thank you. And with respect to my learned colleague, Dr. Hitesh, so the topic and the culprit of today's discussion or debate is pioglitazone, and pioglitazone is on trial. So there is a question, you have to now question yourself and the entire fraternity that is it a metabolic savior or a clinical liability? So my esteemed colleague, today I present a case against pioglitazone, a drug once celebrated for insulin sensitization, now increasingly questions for its safety profile in real-world diabetes care. While it addresses insulin resistance, we must ask at what cost and in which patients does the risk outweigh the benefits. I'll demonstrate through two clinical cases where though pharmacologically it is elegant, often becomes clinically problematic, especially in modern diabetes management where safer alternatives exist. This is my case number one, the common real-world patient. He's 56-year-old male, type 2 diabetic for the last 8 years, BMI 31, with a HbA1c of 8.4%. He's hypertensive and also got dyslipidemia. Mild pedal edema is there, eGFR 68, and he's currently on metformin and sulfonylurea. Pioglitazone might look very attractive here due to insulin resistance, but let us examine the consequences. My argument number one is weight gain, which is counterproductive in obesity, and it causes 2 to 4 kg weight gain, we all know, promotes subcutaneous fat expansion, worsens patient adherence and cardiometabolic profile. In an obesity conference like this, prescribing a weight-gaining drug is inherently contradictory. So these are some data, meta-analysis, which showed how pioglitazone increases weight and also BMI, and you can see in the forest plot that it is inferior, it increases weight. Again, some data, how weight gain happens with uses of pioglitazone in different trials, and these are review articles and meta-analyses which has also shown similar effects. Argument number two, fluid retention and heart failure risk. Already the patient has pedal edema, pioglitazone can retain fluid by the mechanism mentioned here, and it increases the risk of heart failure, hospitalization, particularly in patients with subclinical cardiac dysfunction. So are we treating diabetes or precipitating heart failure in this patient? That is a question. This is some data, again meta-analysis, which showed that heart failure hospitalization has increased in patients who were on pioglitazone. Again, edema increased in all those studies. You can clearly see the data. My argument number 3, inferior to modern alternatives. If you compare with GLP-1 receptor agonist, which causes weight loss and gives a lot of extra glycemic benefits or CV benefits to be precise, and SGLT2 inhibitors, which are indicated as first line in patients with heart failure, and it also gives renal protection. So why choose a drug that causes weight gain, edema, when we have agents that do the opposite of it? Fracture risk, we all know that specifically in postmenopausal women, it increases the fracture incidences in long-term use of pioglitazone. This is my case number 2. This patient is 48-year-old female, type 2 diabetic since 4 years, BMI 27, HbA1c 7.9, and she has evidence of NAFLD NASH, which is proven by biopsy. No heart failure, no edema, normal bone density. Let's look how pioglitazone fits in here. In this case, I acknowledge this is the best possible scenario for pioglitazone, but even here we have concern which remains. My argument number 1, which is a conceded strength of pioglitazone, the NASH benefit, and I agree that it improves hepatic steatosis, inflammation, and to some extent fibrosis also. But pioglitazone has one of the strongest data set in NASH, that I agree, but there are some concerns like risk of weight gain, and then long-term safety, uncertainty is there, and fracture risk, as I have already mentioned. In this patient, my argument number 3 is no cardiovascular superiority over newer drugs is there with pioglitazone, so why not use SGLT2 inhibitors, which gives heart failure benefits and CKD benefits, and GLP-1 receptor agonists, which decreases weight and gives CV mortality reduction. Bladder cancer controversy, my colleague has said that this is very vague, but we have a lot of strong data that showed that it increases overall cancer in our patients. And we work in preventive medicine. Even a signal which exists in long-term exposure has to be taken very seriously. So we have to look into those small signals about the molecules and be careful while prescribing that. This is the data that showed how pioglitazone can increase the bladder cancer, and the A part is from RCTs, and we have a lot of data from observational studies as well. Again, some data with bladder cancer and pioglitazone. Now, I have some questions to my defender, my dear colleague. Would you prescribe a drug causing weight gain in an obesity epidemic like we are having right now? My second question is, how do we justify pioglitazone in patients who are at risk for heart failure? With SGLT2 inhibitors reducing heart failure mortality, isn't pioglitazone outdated? Do you routinely monitor fracture risk in your patients? Is affordability, as you have mentioned, is enough reason to compromise the long-term safety of a particular drug? My closing statements, pioglitazone is not a bad drug, but it is no longer the right drug for most patients. In today's era, we prioritize weight reduction, we demand cardiovascular safety, we aim for organ protection, not only glycemic control. So pioglitazone fails to meet these modern standards for the majority of patients. It belongs not in first line or routine care, but in highly selective patients, carefully monitored niches. We can use pioglitazone with a lot of caution. At last, I want my patient to leave. So look at the all-cause mortality data. This is again meta-analysis. From all the trials, there is no superiority, no benefit with use of pioglitazone in patients. If the patient dies, there is no point treating those patients with whatever molecule you say. Pioglitazone treats insulin resistance, but creates clinical resistance. So being a clinician, we have to give importance to the clinical outcomes, not the theoretical part only. A drug for metabolism should not worsen metabolism in our patients, and in 2026, dear judge and my jury, we can do better than this with the newer molecules that we have in our armamentarium. Thank you.
Thank you for that. Before I hand over to jury for their verdict, I would request my dear friend Dr. A.K. Singh, who's the expert here, to give his expert opinion on the... No, we are not having any rebuttal. Both have presented their case. No, expert opinion and neither. Rebuttal.
You want? 30 seconds, with the permission of judge.
So I have to speak at 5x, I think now. So point is, he has mentioned 5 questions, only single answer to that. He said safer alternatives. Number 1, no drug is sacrosanct. So you can't say, in that case, you will not be able to use GLP-1. It can cause occasional pancreatitis. You can't use SGLT2 because occasionally it can cause UTI and GMI, number 1. Number 2, fluid retention. It's predictable, patient selectable, and avoidable. So you should actually, what are you doing? You should choose patients for the drugs, not drugs for the patients. You first need to understand whom you will give, whom you will not give. Lastly, fracture risk. Risk in one specific subgroup cannot invalidate benefit across the board. Number 4, outdated. So obviously scientific age is not therapeutic irrelevance. And lastly, flozins and tides are better, he has said. So I would say that therapeutic superiority depends on clinical target, not market popularity. And lastly, my last punchline would be, whenever I have a fisticuff and fight with my wife at home, when I cannot win, what I say, कि 7 दिन के लिए हम सब देखना छोड़ देंगे ना, तो family चला नहीं पाओगे. And she relents. The point is here, that once you withdraw pioglitazone from a good prescription, what happens actually? The sugars may go
Time
haywire.
is up. So, expert comments from Dr. A.K. Singh.
So it would be unfair. You would like to speak for 30 seconds, Rupam? You want to defend? No, you have nothing to say? Okay. You want to say? Why are you confused? Okay, fine. That means you have nothing to say. Whether it was a debate or debatable topic or not, I don't know. But look, every roses has got a thorn. So Rupam showed it didn't reduces mortality. Doesn't mean I will not use the drug. Sulfonylurea also do not reduces mortality, nor the metformin, which enjoyed the first line drug for past 50 years. So nobody is defending that a SGLT2 inhibitor or GLP-1 should not be the first line drug. That is there. But you can't manage diabetes with just GLP-1 and SGLT2. If you treat diabetes, you need a number of drugs. No single drug will work, no dual drug will work. Now question is, where is the pioglitazone? The pioglitazone is really a wonderful drug. There is no question about that. If you have to choose between metformin and pioglitazone, who is the better insulin sensitizer, clearly don't write pioglitazone beats metformin. But why it didn't become the first line drug? Because of these baggages. It has got a baggage which we have to be careful, but that doesn't mean that we should not use it. Now look back, if you look at the all current guidelines, the pioglitazone is back. Metformin has gone down after pioglitazone. So in a patients with a atherosclerotic cardiovascular disease, currently the first line drug is GLP-1 and or a SGLT2 inhibitor. What is the next line drug? It is still pioglitazone. Pioglitazone has got the best data on a stroke and myocardial infarction after GLP-1. SGLT2 had zero data on MI and stroke reduction. Indeed, in Imparic outcome trial, there was increase in a stroke with SGLT2 inhibitor. So when it comes to the stroke prevention, the IRIS trial, although it was not done in people with diabetes, the people had insulin resistance with pre-diabetes, but there was a significant reduction in a stroke. So if you have got a patient with a stroke, currently the first line drug is GLP-1, followed by pioglitazone. Yes, we all know that it carries, all those baggages of heart failure. You should not use in a postmenopausal lady. Fracture doesn't happen to a young guy. So if you have got a patient of type 2 diabetes who is at, say, 30 years old, where is the problem of heart failure, fracture and all this issue? Absolutely nothing. Amlodipine also increases edema. That doesn't mean that you don't use amlodipine. So point is that there is a baggage with pioglitazone, but pioglitazone does carry the beneficial part as well. It has got a longest durability data. That's a fact. So my point would be that do use pioglitazone, but remain vigilant, pragmatic. Whenever using pioglitazone, in next follow-up, look whether patient is having retention, any symptoms of subclinical heart failure. If you find there is a gross edema, stop the drug. That doesn't mean that you will not use the drug.
I think those were very valid points. So now I hand over to jury to give their verdict finally, whether Hridesh Narayan wants the case or Rupam wants the case.
Sir, I think the verdict is not in favor or against Rupam or Hridesh. It is in favor or against the pioglitazone. So I think the jury is of the consensus that pioglitazone can remain on the prescription, but with a pinch of salt.
Yes, as Dr. A.K. Singh correctly said, it remains one of the most important drugs in the management of type 2 diabetes in this era. Proper patient selection is very important. Even though the drug has its own side effects, like weight gain and other things, it has to be managed. We have other modalities which are there. We have other drugs which help lose the weight. And it's very important to follow up those patients who are on long-term pioglitazone. You have to give proper lifestyle advice, like you have to improve your resistance training, you have to provide proper diet rich in calcium, and you have to properly monitor their bone strength, and it has to be selectively given to patient. And if a proper patient selection is there, you will get the best long-term results in the management of diabetes.
So I think with all the discussion and both the presentation, I think the conclusion is that pioglitazone still holds a lot of value, but it has to be, used in a very, very patient-centered or individualized manner. And I think that is the case with most of the drugs. Let us give big round of applause for both the, lawyers for pioglitazone. And we move on to the third trial first, because one of the defendants for second molecule is not there. So we are moving to statins, and we have two, persons here. Defense is being done by Dr. Arindam Pandey from Kolkata. Arindam, are you there? And then to speak against will be Shailenjan Roy. 8 minutes each, and we will not have any rebuttal.
Respected judge, juries, panelists, and dear audience, and my dear colleague and little brother Shilanjan. So the topic is statin in younger individual. At the onset, I'd like to thank the organizer for giving me this topic, because I don't see any debate in this. So atherosclerosis, as I mentioned, is a lifelong process. Prevention must begin early. There is no doubt, no confusion, no debate at all. So let us start with this beautiful image, which Shilanjan actually, forwarded through WhatsApp, though with little, twist. Let me show the original, forwarded picture which Shilanjan given me. On the right side, left side, the way I expected Shilanjan to be. So let us try to find out what mistakes Shilanjan did at a younger age, so we don't see the way Shilanjan should have been in today, in current shape. So, and it's very important for the audience, we should not commit the same mistakes. I hope after my talk, everything will be clear. So plaque progression precedes cardiovascular events. Once cardiovascular event has happened, it is way too late. And if you see high cholesterol followed by the deposition and the process of atherosclerosis, early from the fatty streak, it begins in the childhood. We should not have any confusion, any debate regarding that. The process starts at a very young age, and now we call not only a single lipid profile doesn't mean anything. We call it cholesterol years. how long the cholesterol was elevated, that relates to your cardiovascular event. And if you really want to take care of that, if you really want to prevent that, we now talk about primordial prevention, then we need to take care of this cholesterol from a very, very early age. And if you see what the trajectory looks like if you give statin in proper time, now we go even beyond statin. There are many options apart from statin, non-statin therapy. Even we are thinking about injectable medicines to control the lipid. Why? Because of simple fact, we want to prevent events. See, there are multitudes of risk factors, but out of all these, strongest risk factor still today is dyslipidemia. And dyslipidemia, just dyslipidemia doesn't mean anything. It actually gets deposited initially as a fatty streak, followed by some plaque formation. And how do you estimate? There are multitudes of efficacious investigations. Simple one is coronary artery calcium score. Now look at this. The calcium score from 0 means you are not having, to be very honest, any atherosclerosis. From 0 to 100 is the borderline zone. How much time it takes to, from 0 to 100 to reach this time, you need 10 to 15 years. Again, from 100 to more than 1,000, which indicates very significant atherosclerotic burden, it again takes 10 to 15 years. So it's not a matter of weeks, months, it's a matter of years. And if you really want to prevent this progression, you need to start very, very early. And can statin neutralize the cardiovascular risk of unhealthy dietary choice? Even the debate had been like this, and there are many old slides where people try to propose statin in today's young generation, because to be very honest, we all know these are bad foods. We are all very confident that these are atherogenic food, but to be honest, in our household, can we prevent them? So if the prevention is not possible, lifestyle modification is not possible, why not we give some evidence-based treatment from the very early? What the guidelines suggest, this is the 2026 guideline. They say there is a paradigm shift, because they say the paradigm shift towards early prevention. There was a very big debate about the Western guidelines, because if you see, the proper indication of young age statin initiation was not there. But in our country, which is very essential, because in our country, it affects individual around 1 decade early compared to Western counterpart. This guideline suggests if there is definite indication, say for example, more than equal to 160 LDL, strong family history, familial hypercholesteremia, there is no confusion. But the fourth point has been lowered. You can see high 30-year ASCVD risk. Even if your 10-year risk is not very high, they suggest you should actually go ahead and give statin. And the age has also been lowered. As per this ACC, 30 years is a mandatory time when you should screen for statin. What about our country? We were talking about, MI at 20s and 30s, but forget about that. Now we are getting them in the, teens. Even 18 years, 16 year people are having heart attack without any other conventional risk factor. Yesterday I did an angiography of a 32-year-old man who is having heart attack. Last week I did a 28-year-old gym goer with a totally occluded LAD. So why it is happening? If we just follow the 30-year screening, it is not going to be effective. So we need to reduce the screening time. So as per this current guideline, you should begin screening at the age of 2 years if you, think that there are multiple high risk factors. Then again at 9 to 11 years. Then regular checkup. So if you screen and if you find something abnormal, how you are going to counter? You need to give something, and that is actually statin. It is approved to start statin at the age of 9 years. You should be very clear about that. If there is indication, you can start statin even in a 9-year-old, boy or girl. There is no confusion. So is there any evidence? Yes. It is not that too many randomized control trial in younger individual, but I could find someone. This one is good because if you see the mean follow-up is 20 years. WASCOP trial, it was done with pravastatin and 20 years follow-up. does it prevent anything? You can see 31% relative risk reduction of primary outcome. It includes all-cause mortality, cardiovascular disease, coronary heart disease, and non-cardiovascular disease. Similarly, there are other trials. I can show you, more, but this trial is very important. It is not yet concluded. PESA ongoing trial, they have included even the people who are teens. So if you give statin in a proper dose, it is possible to regress the plaque, and there are multitudes of benefits if you start at a primordial way. So if I just finished, atherosclerosis is a long haul process. It actually starts from childhood. Statin is the most evidence-based therapy to counter this. Side effects of long-term statin use, including unmasking of type 2 diabetes, are actually overemphasized. Use of statin is indicated cases from the very young age is not only evidence, it is now backed by current guidelines. Thank you very much.
Thank you. And now we will have the prosecution. Shalanjan Roy.
Slides, please. So first, thank you, EMOCON, for giving me this opportunity, Supratikda, and this, excellent gathering, August gathering. My slides, please. So I'll be talking on, prosecution against the motion, statin in young individuals. My learned colleague, my senior beloved Dada, Dr. Arindam Pandey, has already pointed out towards various points favoring statin starting in the young individuals, but I will oppose the motion straight away and warn you that don't get swayed away by emotions, stick to the science. So I'm against the routine use of statin in younger individuals. Statin are valuable drugs, but good drugs which are used in wrong population, it becomes a bad policy. And in the young, the key issue is appropriateness, not the efficacy of the statin. So first thing is that you have to treat the risk the individual is having and not the age of the individual. Statin should not be used routinely in younger individuals because simply LDL is mildly elevated. That is very important point. Do not look at the LDL value only. Treatment must be very selective, risk-based, and reserved in only clearly high-risk individuals. Unnecessary statin can do much more harm than, based on LDL values only. So first, defining the pediatric population, how do we define? First, we have to age stratify the pediatric population. How can we define? One age group can be below 18 years, that is pediatric or adolescent age group, where the event risk is negligible in the short term. So primary intervention in pediatric age group is only familial hypercholesterolemia treatment or familial, homozygous hypercholesterolemia in the pediatric individual. Otherwise, there is no indication for statin in this age group of less than 80 years. So statin indication is narrowly restricted to FH only or very severe dyslipidemia. In 18 to 29 years of age group, the event risk is very low short term. So primary intervention should be aggressive lifestyle modification, and statin indication is not recommended routinely in any of the international guidelines. We have to focus on risk factor, reassessment, risk stratify. Only in selected individuals they will qualify for statin therapy. In 30 to 39 years age bracket, where the event risk is low to moderate, but the patient is gradually accumulating lifestyle risk, still the primary intervention is lifetime risk estimation, lifestyle modification, and then statin indication in a selective manner only in the patients, as my learned friend has already shown, only in a patient who is having family history of premature ASCVD and LDL only above more than 160. So the key insight is that a 14-year-old guy, a 24-year-old lady or boy, and a 34-year-old gentleman, they are not the same clinical population. Evidence and guidelines differ significantly across all these age group bands. So the first principle is that absolute risk determines the absolute benefit. When the absolute risk is very, very minuscule in the younger population, you can see 99% no ASCVD event is predictable or it is expected in the next 10 years. There is no point in treating these less than 1% individuals calculating the 10% ASCVD risk. So low absolute 10-year ASCVD risk means that immediate absolute benefit of statin is mathematically negligible in most of the young individuals regardless of the relative risk reduction that statin can provide. And there is another problem of treating the patient, the burden of treating for decades. So a 60-year-long prescription of statin, you can think if you start statin at the age of 25 and the patient lives up to age of 85, 60-year patient has to take statin. If you start at the age of 35, maybe 45 to 50 years of daily continuous therapy. So what are the harms? Uncertain long-term exposure data across a full lifespan. We don't know what will happen if a patient takes statin for 45 to 50 years, 60 years. There is a compounding financial cost without any clear benefit data. There is a daily adherence burden, and the most important, labeling an otherwise healthy young person as diseased. So starting a statin at 25 means a lifetime of pharmacotherapy. We lack long-term data to justify that across an entire generation of healthy adults, there is any utility of this long-term use of statin therapy indiscriminately. So the primary pathway of risk reduction should be root cause intervention and not to statinize. So what should be the ideal way that young patient who is having an unhealthy lifestyle and mildly raised LDL, the key solution should be behavioral change by dietary interventions, by exercise, weight control and tobacco avoidance, and not by statinizing the individual. So it should be given only in clearly high-risk individuals. A population-wide start early drug approach, it diverts the entire clinical attention from the root cause interventions to pharmacotherapy. So if the main driver is unhealthy lifestyle, the first prescription must be behavioral change and not lifelong pharmacotherapy. That is one of the very important point. And now look at the science, the guideline, the reality matrix. All the guidelines that they are proposing very selective prescription of statin in this particular age group, not a universal statin prescription. ACC-AHA, the approach should be targeted in the young individuals, prioritizes the lifetime risk estimation and lifestyle for 20 to 39 years age group. Statin trigger, it should be considered only very selectively where there is a strong family history of ASCVD or the LDL is more than 160. ESCAS, pediatric treatment focuses very narrowly on genetic anomalies, that is patient having congenital homozygous hypercholesterolemia. These are very small proportion of the patients, and unless they are, you pick up this genetic abnormality, there is no point in treating pediatric individuals with statin indiscriminately. It supports targeted use around 8 to 10 years strictly for familial hypercholesterolemia only and not other causes of increased LDL cholesterol. What is the Indian life perspective? Though it acknowledges that earlier ASCVD onset in Indians, but it stresses lifetime risk assessment should be the main factor to determine whether the patient is a candidate for statin or not. Aggressive prevention is indicated for high risk group, but it also cautions against the indiscriminate statinization because Indians are prone to have higher statin levels in the blood with the same dose of statin. That increases the risk of statin induced complications also, and there can be risk benefit mismatch. So you can see profile A, truly those who are high risk individual of familial hypercholesterolemia, severe LDL elevation, definitely they are going to have benefit. So their statin is indicated, do not deny treatment, but in average youth with mildly LDL cholesterol, there is a very negligible short-term absolute benefit. Event risk is inherently low and the likely concern is decade long of medication exposure, adherence burden, cost. So it is still not indicated. The benefit curve is steep only in the selected high-risk young individuals. In the majority, the math does not support the routine prescription. So my message is very clear. The same thing, benefit curve is steep only in the young, selected subgroup. What is the risk of overtreatment? So the cost of imprecision, this is the overtreatment funnel you can see. A single lipid value metric can lead to medicalization, labeling completely healthy young individuals as diseased by statinizing them, therapeutic inertia, patients rely on the medications and the pills only, abandoning the crucial lifestyle and dietary changes, and poor adherence, long-term compliance collapses when the patient feels healthy and perceives zero short-term benefit. So what it happens, it makes society full of healthy young individuals into lifelong patients. So over-treatment is not prevention. It is imprecision that is disguised as prevention. So accumulating harms, when the baseline risk is very tiny, even small adverse events, they gain substantial clinical weightage. First is the burden of excess muscle and hepatic symptoms, statin-induced myopathy, hepatic enzyme elevation, increased glycemic burden, though the risk is small, but increases in blood glucose and incident diabetic risk, especially that is critical in the individuals who are already predisposed to metabolic disease, like the Indians, who are already predisposed to this risk, and also pregnancy considerations are there. That is my final take, that statin in the young, where selectivity beats the routine use, we should be cautious. Selective guideline approach in different age bands, and we should not go for, indiscriminate use of statin therapy. Thank you very much.
Thank you. Now I would request Dr. A.K. Singh to give his final comments before I hand over to Julie. No rebuttal.
So now it's rule is changed as per the wish of judge, so I can't, surpass the judge's decision. Well, so both of them have presented their point of argument. But the point remains is, for primordial prevention, Arindam was speaking about, and he shown slides that look how the young generation eats burger, pizzas. So we should start a statin in those young children. Absolutely no question comes. Pharmacotherapy cannot be used for primordial prevention. Don't allow your children to have a burger and pizza because he will develop atherosclerotic cardiovascular disease, and you allow them and say, look, take a statin and keep on taking burger and pizza. This formula doesn't work. Now, see, the point is age. First of all, age should not be the cutoff for having a statins, that I agree. Someone, say even a 25-year-old having a, evidence of atherosclerotic cardiovascular disease, means secondary prevention cohort, statin is for all in people with secondary prevention. The question comes is where to go in a primary prevention. That should be the debate. For the primary prevention, what should be the age cutoff? Look, for the diabetes, as you all know, all guidelines suggest you at the age of 40 years. So the question comes is why 40 years? Why not at 35 years? Why not at 30 years? There has to be some reason. People making a guidelines are not a fool people. They look at the evidence. The evidence is very clear that because we learned that the only trial which was done in patients with type 2 diabetes for a primary prevention was a CARD trial. The other trials which supported the finding from the CARD trial was HPS and Scott LLA. But these were not actually primary prevention trial. They had HP was a primary secondary prevention trial. Scott LLA having both primary and secondary. But the only trial which actually taught us that in patients with type 2 diabetes, even if you don't have atherosclerotic cardiovascular disease, that is primary prevention cohort, in only CARD trial we could show that a statin produced benefit. Now where from the age came? Because in all the three trials, the age was 40 to 75 years. So there is no study in planet that studied a statin in people, those who are less than 40 years of age. And therefore, the cutoff by the ADA guidelines has put for primary prevention in people with type 2 diabetes is 40 years. But if you look at the recent findings, we did learn that a 30-year-old diabetic may have a high cardiovascular risk. If he has got, say, albuminuria, left ventricular hypertrophy, family history of atherosclerotic cardiovascular disease, there of course you should start a statin, regardless of what his age is. So people with even type 2 diabetes with a high cardiovascular risk, if they are even younger than 40 years, one can start a statin. But saying that you can use a statin in a younger age to prevent as a primordial prevention, we should use a statin, is not at all acceptable.
So over to Julie for your decision.
So Dr. A.K. Singh sir has very well formulated, and I'm so sorry, but statin is not an anti-aging drug. As you showed the first slide, the Chilanjan started early, would not have been today what he is. So statin is not an anti-aging drug. And you also quoted a child of 9 years being on statin. See, there are conditions as familial hypercholesterolemias are there, we are treating them, but that does not go as a rule then. So age and statin is not correlated. As sir rightly has put up, it is the primary prevention in selected cohort. And that selected cohort again may not have any age criteria. So statins are justified molecules in the right population.
Yes, I would like to add a couple of points. Most of them were told by Dr. A.K. Singh. The first thing, starting a statin doesn't make you a patient. It's just a preventive strategy. You don't become a patient by just being on a statin. You are preventing a disease, so it's not a treatment, it's rather a prevention. Second thing, if you look at the 2026, that picture you showed, it doesn't force you to start treatment with statin. It just asks you to screen, and it reinforces lifestyle management before before using statin. So that's what we should be more looking at. We should be screening the younger individuals and reinforce lifestyle measures, as Dr. Kesing has said. The next thing, it should not be a blanket treatment in young individuals. Just like we prescribe a vitamin D, it should not be a blanket treatment, especially in women of reproductive age. Even though we have seen very high levels of LDL, we are not supposed to use it. And just because of the age cutoff, it should not be delayed, as you showed that 85 years graph. So if you're giving statin to an appropriate person at 35, you are justified in continuing it up to 85, because that person will live longer. But if you are missing a statin in an individual who deserves it at 25, that person may not live till 40 years of age. So it has to be the right person. And that's all from me.
So I think we are very clear after the remarks that statins are there. They are important drugs for primary prevention, but they have to be used judiciously, and we cannot undermine the role of lifestyle interventions in primary or primordial prevention. And every drug has to be used judiciously. With that, I think we should have a big round of applause for both the defender and the prosecutor for the topic. And we move on to the final case, which is the DPP-4 relevance in GLP-1 era. And to defend, we have none other than the ferocious fire Arvinda, and to cool off him will be there Dhruvi. Arvinda, 8 minutes.
Yes, sir.
7.5 for you.
No. So good afternoon, everybody.
Timer, please.
At the outset, we have got an interesting debate, interesting topic. Can I have the slides, please?
Timer on, please.
So my debate is DPP-4 inhibitors relevance in GLP-1 era. So I'll be talking in favor of DPP-4 inhibitors. So first of all, greetings to all of you from Bangalore. So in the current era, who holds the relevance? DPP-4 inhibitors or GLP-1RA? So GLP-1RA, sure, is a rising stars. DPP-4 inhibitors are called obsolete. Are they really irrelevant? Is DPP-4 inhibitors retired or is just underrated? In the GLP-1RA era, everyone thinks DPP-4 inhibitors are outdated, but let's be honest, some classics never go out of style like clinical wisdom. So GLP-1RA, better HbA1c reduction, weight loss, CV benefit. Therefore, DPP-4 unnecessary? Is that the question? My opinion, not better versus worse. It's about right patient, right drug. Not replacement, it is the coexistence. So changing diabetes landscape, type 2 diabetes management has evolved from glucose-centric to cardio-renal and weight-centric approach. GLP-1RA dominate guidelines due to superior HbA1c reduction, weight loss and cardiovascular benefit. Does better means replace all other OADs? No. So therapeutic progress should expand options, not eliminate useful ones. Or the guidelines they assume ideal patient access, ideal adherence, ideal affordability. Majority of the real world patients are older, cost constrained and polymedicated. So guidelines are recommendation, not mandates. So guidelines guide, but clinicians treat the real world patient. So DPP-4 inhibitors offers oral once daily therapy, glucose dependent insulin secretion, no hypoglycemia, weight neutral, excellent tolerability profile, safe in elderly and renal impairment patients. Glycemic efficacy, accepted limitation is GLP-1RA. Yes, robust glucuron reducing HbA1c reduction is by 1 to 2%. DPP-4 inhibitors 0.5 to 0.8%. You can see mild hyperglycemia, the recommendation is DPP-4 inhibitors is sufficient. Moderate to severe hyperglycemia, GLP-1 needed. Avoid over treatment, ladies and gentlemen. Not every patient needs a bazooka for a mosquito. So weight aspects, GLP-1RA, weight loss, we know, DPP-4 inhibitors, weight neutral. In lean patients, neutrality is equal to advantage. Weight loss is beneficial but not universal. In elderly lean patients, sarcopenic risks are there, frailty concern is there. Being a weight neutral can be protective. So not every patient needs to lose weight. Some need to keep it. So CV outcome reality, if we take GLP-1RA, proven CV benefit, DPP-4 inhibitors, CV neutral. Neutral means it's not harmful. Not winning doesn't mean losing. So cardiovascular safety, you can see there are various data available with DPP-4 inhibitors. Neutral means not inferior in low risk patient. Not every patient need more. Some just need enough. So CKD use, DPP-4 inhibitors safe in CKD, no dose adjustments, practical advantage, especially with linagliptin is there. Elderly and frail patients, DPP-4 inhibitors are safer, less weight loss, better tolerance. So ideal for frailty. Better glycemic variability with DPP-4 is available as shown in this J. Victoria study. Safety and tolerability, a key DPP-4 inhibitor advantage, extremely low discontinuation rates, minimal GI side effects, safe with polypharmacy and suitable for long-term use. In contrast, GLP-1RAs shows higher rates of treatment interruption in real-world cohorts. So DPP-4 inhibitors are having very low GI issues, very low hypoglycemia, and very low weight changes. A clean drug is the safety profile. Hypoglycemia, both classes, no low risk. DPP-4 inhibitors are extremely safe, advantage in elderly. Tolerability, GLP-1RA, we know nausea, vomiting, loose motions. DPP-4 inhibitors are very well tolerated. Adherence matters more than potency. I'm sure all of you will agree. Not every patient loves needle as much as we do. Studies conducted in India and globally indicate needle phobia is highly prevalent with estimates of 30.9 to 63%. So injection fatigue is real. The needle phobia exists across the patient subgroup irrespective of education level, socio-economic status, urban and rural settings. Even Mr. Bean fears a needle. Patients say yes to drugs but no to needles. So there are so many GLP-1 concerns. They say whether to take injection every 4 weeks, it has to be increased like that. Cost and accessibility, DPP-4 inhibitors are cheaper, GLP-1RA are expensive. As shown in this study, you can see the ease of DPP-4 inhibitors in treatment algorithm is very important. Simplicity in practice, once, twice, weekly oral, unlike GLP-1RA, no titration needed, minimal monitoring, high physician and patient comfortable. Adherence is better with the DPP-4 inhibitors as shown in this real world studies. See, Dhruvi is telling this, if adherence had a voice, it would quietly vote for DPP-4 inhibitors. Even Dhruvi is accepting it here. So choosing between GLP-1RA and DPP-4 inhibitors, not all patients can afford GLP-1, tolerate GLP-1 and need GLP-1. So GLP-1RA is powerful, DPP-4 inhibitors is practical. The balanced view is medicine means it doesn't mean one size fits all. It is not equal to one size fits all. GLP-1RA is like a luxury SUV. DPP-4 inhibitors is a reliable sedan. The final argument, ladies and gentlemen, GLP-1RA limitation, why alternatives matter. It's injectable, GI intolerance, weight loss not desirable to all, higher discontinuation in real world use, high cost and access inequality. So best drugs is not equal to best for every patient. So there are GLP-1 concerns. You can see retinopathy, 4 weeks they increase the dosage, depression, muscle loss, multivitamin deficiency. Would still benefit from DPP-4 inhibitors? Elderly patients, lean or near target BMI, frail or sarcopenic patients, GI intolerant, injection averse patient, cost sensitivity settings, moderate CKD patients. If GLP-1 RA is IPL cricket, exciting and aggressive, DPP-4 inhibitors are test cricket, stable, predictable and dependable. So, key take-home message, GLP-1 RAs are powerful agents but not universal solutions. DPP-4 inhibitors offer safety, simplicity, tolerability, affordability. Weight loss is not always desirable. Guidelines guide population, clinicians treat individuals. Modern diabetes care thrives on choice, balance and personalization. In the current era, both hold relevance, winner when used right. Diabetes care is not a knockout match, it's a long-term partnership. Yeah, I'm thinking the hall is become very hot. Let us have some Durandar style. You can see here, DPP-4 inhibitors, you can see here how it is there.
Arvinda, it's over.
So, ladies and gentlemen, in the GLP-1 era, DPP-4 inhibitors are not obsolete. They are essential for
Arvinda, this is over now.
Thank you so much.
And we are going to give you some negative remarks also.
So, respectable judges, experts and the jury, my esteemed audience and colleagues and friends in the hall, till the slides come up, I think one of the best debatologists in our scientific arena has made my job easy by showing that both of them are relevant, and you've been constantly debating with the points that
can we have the
DPP-4
slides?
is not for all.
Slides and timer both.
Cool. So allow me to tell you all that GLP-1s have been there in the industry, in the market, in the clinical segment for management of diabetes and obesity since quite some time now. What we will all have to understand is that both of the molecules are on the backbone of incretin therapy, which gets stunted whenever somebody has insulin resistance, whenever somebody has both diabetes and obesity. In this 2026, when a clinician, my jury, prescribes a DPP-4, what we are doing is complacency. What we are talking about is the clinical inertia. When we have the oral GLP-1s, when we have the injectable GLP-1s, a very bagged, evidence-based molecule, which is there not just for efficacy, but it has its proven safety for the entire CKM syndrome. Why are we not prescribing a molecule which is kicking out the relevance of the DPP-4 that are not giving just the sufficient aggression that the younger population as well as the elderly. We've been hearing my previous esteemed defense attorney talking about how the frail elderly do not require semaglutide, do not require GLP, do not require any incretin-based therapy, which would cause some sort of a sarcopenic obesity or a format wherein they might not accept injectables. That is not the case. We need to give the best therapy as an option and not talk about something which creates complacency or inertia in our day-to-day practice. It is not justified when a superior class is present. Our expert, Dr. A.K. Singh sir, just said that the guidelines are not made by fools. They are backed by evidence. They are backed by people who've been working since a huge amount of years, and the evidence right now, the guidelines are also saying that if you have ASCVD, a risk factor of ASCVD in a person with type 2 diabetes, your first choice should be GLP-1. In case that the person has any risk of CKM or one of the stages of CKM, what should you be first prescribing is a GLP-1 molecule. If there is heart failure, what should you be prescribing? It is the GLP-1 molecule. In case you want weight loss, which is now the case, we are not just glucocentric, we are adipovascular glucocentric in our approach. We want a disease modifying molecule, my esteemed jury expert and the judges. We should use a molecule which gives us all of it. The guidelines again, in 2026, they are very clear as to the use of a best-in-class molecule for the entire CKM syndrome, which includes diabetes, obesity, the vasculopathy, the endothelial dysfunction, which we all want to target in people across age category and not just elderly, not just, young population, across the spectrum of diabetes. It is the GLP-1s who are going to score better and kick off the DPP-4 and shun off the relevance of the DPP-4 inhibitor. This is one of the papers from 2021, 5 years ago, when the GLP-1s were compared with the DPP-4 in the clinical practice. Of course, this is from the Swedish, the Scandinavian countries. But if you understand and if you looked at the conclusion over here, GLP-1s were associated with a reduction in the kidney and the cardiovascular outcomes in comparison to the DPP-4. What more do you want? A head-to-head trial in so many people. Another comparison between the once weekly GLP-1s versus the DPP-4 in such a huge population versus the DPP-4 inhibitors, and what are they showing? That again, prescribing a GLP-1 injectable molecule is going to give you the cardiovascular benefit and keeping those people away from any events that you want to prevent. Why GLP-1s are winning? They have, of course, a powerful HbA1c reduction. Even if you don't look at any other pleiotropic benefit, you want a strong HbA1c reduction, which is 1 to 1.8%. Across the LEADER trial for liraglutide, the SUSTAIN trials, the REVINE trial, any of the CVOT trial, the SURMOUNT, the STEP trials, everywhere GLP-1s have shown their benefit in terms of HbA1c control, weight loss, which is a significant weight loss when we talk about, again, disease modification. We just don't talk about good numbers. We talk about a good quality of life to this person living with diabetes. Of course, the cardiovascular benefit, and the number is 20% when it comes to reduction in MACE. Multi-organ protection. Why do you want to just give a good glycemic control when you can give it all? And it is an outcome-driven molecule beyond glucose control. Again, it's not just HbA1c for one time. It is a consistent and a stable glycemic control along with the pleiotropic benefits, Dr. Jagdisha, that we want to give. I understand that you've defended the DPP-4s very well, but you will have to accept that when there is both injectable as well as an oral formulation of such a best-in-class molecule, then why should we not prescribe that? And this is just a little bit for the DPP-4. They are inferior in efficacy. I don't have anything in favor of DPP-4. They have inferior efficacy, of course. No cardiovascular benefit. You yourself showed that. They do have safety concerns. The SAVOR-TIMI trial did show that there was an increase in hospitalization. No added value when they are used in combination. So I'm not talking about any other class that needs to be shunned out, but I am talking about a molecule like DPP-4 which can be shunned out. There is no longer a relevance of these molecules in our prescription paper. There was always an argument about the cost, which the Indian market is not seeing anymore. We have the class available in the best numbers. And even if we are an out-of-pocket country, it is a very affordable molecule now. The guidelines have moved ahead. Every doctor is moving ahead. Then why shouldn't we? Why are we still debating this? The relevance is going to go away for DPP-4. We are going to prioritize GLP-1 RAs in people with ASCVD, in people with obesity, in people who have high risk for CKM. So DPP-4 is falling back. That's the thing. So let's continue talking about the prescription of GLP-1s. DPP-4s are not patient-centric. They are not evidence-based. They are not future-ready. We have an entire line of incretin-based therapy that will be coming into the market soon. So the relevance of DPP-4 is just a habit-based prescription. We need to come out of that inertia. We need to come out of that habit. Medicine has evolved. Now prescribing an age-old molecule is a compromise for all our people with diabetes. And with that, I'm going to save the 52 seconds. And I also have some points, if I may. I wrote it down. So the needle phobia, Dr. Jagdisha, is an inertia again. It was there with insulin, but we are still prescribing insulin. There are PCSK9 available in the injectable format. We don't shun away from prescribing those injectables. The antibiotics are in an injectable format. We still prescribe those. So not all diabetes, people with diabetes are elderly. There are young people, there are the middle-aged people who need aggressive care. So with that, yeah, those were my points. I think I use those 50
Time is
seconds.
over.
Yes. Thank you.
Thank you.
Well, first of all, Arvinda, playing a music in a debate is not allowed. In a court. That too in a court in front of jury, expert and judge is a criminal offense. मैडम ने बोल दिया कोर्ट की मानहानि हुई.
मानहानि आप पे अवमानना का दावा किया जाएगा.
So contempt of court में वैसे भी you are losing the game in the science as well. So why to discuss DPP-4 inhibitor in a GLP-1 era? Now if you ask Ralph DeFronzo today, should we use a DPP-4 inhibitor? He says the DPP-4 inhibitor is a placebo. And actually DPP-4 inhibitor, just I would say, I would be a little bit, biased. I would say it is little better than placebo. But then you cannot question GLP-1 in today's world to the DPP-4 inhibitor. Having said that, look, in science aspect, GLP-1 is an ocean and DPP-4 is a drop of water. That's it in that ocean. Now, that doesn't mean that I will not use that drop. Drop matters. Not every patient would wish to go for an injectable, as you said. There is, of course, injection phobia. Nowadays, maybe cost has come down. People might now prefer because of the cost issue. The cost was earlier issue, is no longer nowadays with the synthetic, semaglutide currently in the market. But when it comes to science, you have got no space in any guidelines today in the world. DPP-4 inhibitor is no longer available in any guidelines in the world. That doesn't mean that we don't use it. We have to use it because we have no option. Because our patient may not able to afford GLP-1, they may not like injectable drug, they may not like initial GI side effect which is there with the GLP-1. So that part is there. So basically this is a DPP-4 inhibitor we are writing as a majburi. और मजबूरी का नाम DPP-4 inhibitor.
So, if I may add, DPP-4 inhibitors have few more advantages, what Sir probably forgot to mention. One is they are very subtle molecules. They are not loud molecules and they are available as combinations. So, the pill burden still goes down. So, whenever you are prescribing a GLP-1 RA, maybe a biosimilar, maybe the economical versions, but still they are very loud molecules. They need to be discussed, they need to be taken a permission from the patient. They need to be, a lot of counseling is needed when you are prescribing a GLP-1 RA. Whereas when you are prescribing a DPP-4 inhibitor, it takes a lot of less time. You just write and you send the patient off. So if you're in a hurry, as I am right now, DPP-4 inhibitors still stay. But yes, in cretin-wise, they are a bit like facing the death sentence probably.
So I think, though my, expert here, AK Singh, is, we call him AK-42. So, 47. So, he is very, emphatic whenever he is talking on a subject, and the conviction is backed by his, phenomenal knowledge also. But if you look at the guidelines, I don't think DPP-4 are out of all the guidelines. They still have a place, though they have a limited place, and they are mentioned in a small area where it talks of type 2 diabetes, garden variety without any complications, and you are initiating a drug, and you are looking at A1C reduction of only 1.5%. It is a good combination still there. Now, keeping in mind the kind of population we have and kind of, reach we need at primary care level, I think DPP-4 inhibitors in a combination with metformin are still very relevant molecules, and the reach of GLP-1 is not that. Yes, GLP-1 has definite advantages over DPP-4 inhibitors, but there are certain groups, especially elderly, where challenges can be there. So, or the mild diabetes, mild age-related diabetes, mild late onset diabetes, all these cases we can still do with the DPP-4 inhibitors, especially in general practice, in primary care practice, in rural belts where the follow-ups are poor, all those places, DPP-4, I think, still have a role. So there was a good debate. Again, good round of applause for both the speakers, and a big round of applause for our expert and our jury. And we hand over back to the organizers. Thank you.
Moving ahead to our next session, for that I would like to invite our chairperson for our next session, Dr. Indrashish Mukherjee from Lucknow and Dr. Mahua Sikdar from West Bengal. So I invite both the chairperson, and for our topic, Dr. Meena will be taking the first because she has a flight to catch. Thank you so much.
Okay, Meenal ma'am.
A very good afternoon, and with the kind permission of the chair, as my introduction has already been done, I will begin the session. See, we are moving ahead. We are moving very fast now. And it is something the next dream come true in the world of diabetes management. When you talk of diabetes management, the next dream. One time we had dreamt that we will have oral insulins, we will have inhaler insulins. So that day has come. Now we are awake and we are the dream come true is here. So these are my disclaimers. This is a sponsored session by CIPLA, and we are here talking about Afreeza. We all know insulin as the age-old molecule. So it has been a century, more than a century, that insulin was discovered in 1920-21 by Benting and West. Then we dreamt of having oral insulins or inhaler insulins. So what is the evidence with this product today? We are using it. Yes, we are using it. And we will conclude with our final remarks. Insulin, as we all know, we started our journey with bovine insulin, porcine insulin, and then we had human insulin, and then we also had the recombinant DNA technology, that is analog insulins. So we also moved in pharmacokinetics. We used to have the basal insulins, intermediate insulins, the lente, the ultra lente, then we had the true basals, and then we had the true ultra long acting insulins. Similarly, we had the prandial insulins, that is the short acting, that they were the regular insulins, then the rapid acting, and finally we had the ultra rapid also with us. We also moved in our journey of comfort. We started using from the syringes and vials, we started using the disposable syringes, then we had the ultra fine devices, the insulin pens were available, and then we also had the insulin pumps, the no prick technique, just push a button and the insulin is delivered. And from here now we are moving to inhaler insulins. So now that is a huge comfort that you just need to inhale the insulins. Inhale means through mouth, of course. So in all this journey, the two things which never were lost, one is the insulin itself, that's the molecule is still insulin, and the needle. The needle was always there. Now we are moving to the inhaler insulins. So the journey was actually started again a century back, sometime in 1925, when the concept of inhaler insulin was conceptualized in Germany. Then it was first tried in 1971 on rabbits. Then finally the Exubra was in the market, if some of us have must be remembering, and some of us must have also used it. So Exubra by Pfizer, it was in the market, and it was a huge noise level that wow, we have the inhaler insulins. But unfortunately we were all disappointed, and the molecule was withdrawn within 1 year. There were a lot of asthma attacks and coughs, and intolerance was there, the bronchospasm was aggravated, so it was withdrawn. Then in 2004, Mankind, not the one we are dealing with the single N, but with a double N. So this is a Mankind cooperation of USA who brought Afreeza and got it approved from US FDA. Then there was a collaboration of Mankind and Cipla got the marketing rights in India, and finally we are now having Afreeza on our prescriptions, in our chemist shops we have Afreeza available, and we are using Afreeza for all our patients. Going scientifically, the molecule is Afreeza, the brand name is Afreeza, but we call it technosphere insulin. So what is a technosphere insulin? Technosphere insulin, it's a rapid acting insulin. It starts quickly. Within 5 minutes it starts acting, and it is out of your system in 1 hour. So it's a very rapid acting and a very short acting insulin. It is used by formulating insulin with a binder which is called FDKP, that is fumarate diketopiperazine polysorbate 80. So it is FDKP. This FDKP makes it possible for the insulin to be inhaled and reach the alveolar epithelium. So it reaches the alveolar epithelium where the pH difference allows it to dissociate rapidly and it gets absorbed rapidly. So it was approved by US FDA on June 27, 2014 and is now commercially available with us. It is a very compact device. If you look at the device, it's a very small device. You can carry it in your pockets available here. With pre-filled cartridges are available presently in 3 strengths, the 4 and 8 and 12. Here you can just substitute 1 unit for 1 unit. So if any patient on up to 4 units of insulin can be given 1 cartridge of 4 units, and they have a color coding. So they come in 3 colors, the blue, green and orange. So this is the FDKP, this is the microparticle, this pointer is not working actually. So this is the FDKP, that is fumarate diketopiperazine, and this in combination with insulin, the human regular insulin, this is a short acting, only the bolus insulin is available as inhaler so far. So this is inhaled, and the pH, as I told you, is acidic, but the pH inside the alveoli is physiological pH, that is around 7.4, of course more than 6. So it is rapidly absorbed and it reaches the blood circulation and it quickly starts acting. So it's a short acting, rapid onset and very short acting insulin. Now this is a very long statement to read, but the crux is that anybody using Afreeza or a technosphere insulin should have a prerequisite of PFT done. So the pulmonary function tests have to be done and your FEV1 has to be more than 70% before you prescribe Afreeza. So no history of smoking, no history of COPD, no history of asthma, no ILD. So lung diseases are not the patient group where you can prescribe Afreeza. So the prerequisite is that your lungs should be healthy to prescribe Afreeza. So the technosphere insulin, so we have a huge data with us. So there are more than 60 clinical studies with more than 6,000 patients, and this molecule has undergone a lot of research and trials, phase 3 trials also and phase 4 trials also. The Indian trials are still on, and we have a huge burden, huge data with type 1 and type 2. The molecule we have still not studied in GDMs or the pregnancy diabetes or the lactating mothers, but we don't find any reason for any contraindications. So if you look at the pharmacodynamics and the pharmacokinetics of the molecule, you will find the pharmacodynamics. So the insulin rise, as the insulin, the technosphere insulin is injected and compared to the Lispro, that is the subcutaneously injected insulin, you will find that the glucose rise, it matches the glucose peak and it quickly comes down also. So it's a rapid onset and a short acting molecule. If you look at the insulin curves, the rise in insulin is also peaking and matching your glucose peak, and it also quickly comes down. So if you look at this table, you will find that it is very much physiological. So endogenous insulin starts rising in 10 minutes. Similarly, Afreeza starts acting in 12 minutes. You will find the subcute insulin, it starts acting in 15 to 30 minutes. Time to peak endogenous insulin is 45 minutes. Similarly, Afreeza also peaks in 45 minutes, whereas the subcute rapid acting insulins, they peak in 2 hours, 90 minutes to 120 minutes. Washing out period for endogenous insulin is 210, that is almost around 3 hours. Similarly, Afreeza also washes out in 3 hours. So it is very much physiological and you can very safely use it. Looking at the clinical data, the HbA1c reduction, if you compare it with a rapid acting insulin, that is Aspart, it is quite comparable with a p-value of less than 0.05. So there is no 0.05, it's more than 0.05. So it is matching your non-inferiority qualification. So whenever we compare any new molecule, we only just try to justify that it is not inferior to the existing molecule. So the study showed that Afreeza is non-inferior to the rapid-acting aspart. Similarly, if you look at the episodes of hypoglycemia, the hypoglycemia was very, very less as compared to aspart, and similarly, the episodes of severe hypoglycemia were still less. Now, if you compare the molecule with a placebo, here they have compared the molecule, the technosphere insulin in combination with a long-acting, that is a degludec, and the usual care, that is a basal bolus, that is aspart plus degludec maybe. Again, the data shows that it's a non-inferior molecule giving you an HbA1c reduction which is comparable with no incidences of hypoglycemia. So, it is comparable everywhere. This is the CGM data which is showing that the data below time, below range was also comparable. So, Afreeza has shown very good results in most of the clinical studies and the clinical data. Now, if you compare that molecule with a placebo, this is a technosphere placebo. Obviously, a placebo will have no hypoglycemia. So, if you compare the episodes of hypo in technosphere insulin versus a placebo, definitely the hypo is bound to be more with the technosphere insulin. But if you look at the data as comparing the postprandial controls, the postprandial controls are very good with the technosphere insulin, whereas placebo has no effect. HbA1c reduction has also been shown to be very good with the technosphere insulin, whereas the technosphere placebo has no effect at all. So this is a very understood, like something which we can really correlate. Now looking at the side effect profile, so cough incidence is the highest reported side effect. With placebo, there is no side effect at all. But yes, even the technosphere placebo, if patient is made to inhale, some patients will report some coughing. Otherwise, cough is the highest reported side effect with technosphere insulin. FEV1, if you look at the follow-up data, FEV1 has remained stable throughout the study, though a reduction of FEV1 of up to 20% is quite acceptable and which is reversible. Looking at the special group of population, the molecule has not yet been exhaustively studied in the special population. Neither we have done a study with the pregnancy group or the lactation groups. We are still to find the data with renal impairment or hepatic impairment. In children, we have not used it because finding a child to inhale that insulin and blow out and reaching that FEV1 level is still not very clinically feasible. In geriatric population, again the same challenges of the lung capacities, they limit our studies with the molecule. But thinking scientifically, a molecule, it's just an insulin, another way of delivering insulin, the same insulin. It should have no severe side effect if we talk of the CKD or the CLD group. So the molecule should be safe in pregnancy also, but we don't have a data so far. So clinical safety, the side effects, as I told you, the most highest reported side effect is cough. Rest all are just in the very limited number of 2% or 3%. Some patients will report throat irritation or headache or diarrhea, some productive cough or fatigue or nausea, which are not clinically relevant, but most clinical relevant and the most common reason for withdrawal is also cough. But the studies show that the cough incidence starts decreasing as the patient keeps on using the molecule. And this cough is reported only in the first 30 minutes of inhaling the insulin, and that is also with the initial doses only. It does not persist. So the pulmonary safety, though we have as I told you, though there were reported FEV1 reductions, but they were very small, and they just happened in the early phase of the beginning or the initiating the molecule. And once the patient was continued on the molecule, there was no further FEV1 reductions. And if you discontinued the molecule, the FEV1 recovered. So this is the FEV1 data. You will see that there were only maximally there was a 5% reduction. Up to 20% reduction, hardly there were any patients. But if you at all come across a patient and shows more than 20% FEV1 reduction, please stop the molecule. Lung malignancies, no reported cases so far to document it clinically correlating it with lung malignancies, though in the entire cohort there were some 2 reports of lung cancers, but probably they were already heavy smokers in the past or they had some other family history of lung malignancies. So finding the correlation between the molecule and the malignancy has not been possible and it is not even suspected. So coming back to the basics,
So we have the molecule cartridges available in 3 units, 3 formulary or the 3 denominations so far. The 4 units in blue color, 8 in green, and yellow is in 12 units. Conversion rate is very simple, 1:1 so far what we are doing. They are used as oral inhalers. The packing strip is available. You just tear off the one strip, press from the clear side. This is the device. It opens like in this way, and then you can press it on there. It is a one-time usage cartridge. One strip which you are using it and opening, the remaining 2 cartridges should be used within 3 days. So Technosphere insulin, it's a rapid-acting insulin available to be used in type 1 and type 2 diabetes population. It is not recommended for emergencies, not recommended for DKA, not recommended so far for pregnancies, and clear contraindication in lung diseases. So I think that would be the last slide. So before initiating Technosphere insulin, please go for PFT, assess FEV1, it should be above 70%. Assess FEV1 after 3 to 6 months. If you find a drop of more than 20%, please withdraw the molecule. Otherwise, you can continue and assess at 6 monthly and annual intervals. So Afreeza, the molecule, the dream molecule, it is ultra rapid acting insulin available with us in the market now, and I think it's quite safe. Rapid acting, short acting, with very low risk of hypoglycemias, and preferably we all must have got the clinical experience so far. We all have already used the molecule now. So with that, I thank you all for listening to me, and thank you Nandita for allowing me to talk. If you have any questions, I'll take up on Afreeza.
If you have any question from the audience, if not, may I ask a question? Very practical one, just to initiate Afreeza. What are the precautions and what are the practical points we should remember?
What I can tell you my experience, what we are doing, we make every patient undergo a PFT. So we have the spirometer with us, a PFT report above FEV1 above 70%. We teach and train the patient how to use it with our demo devices and the cartridges. We calculate the dose. If it is a basal bolus patient of 4 units 3 times and basal remains, basal has to be combined with it always. It is only the bolus that we are replacing. So a patient on 4 units, we start with a blue cartridge, and if anything above 4 but less than 8, we go with the 8, that is a green cartridge. Anything above 8 but less than 12, we go with the 12 cartridge, the yellow one. If it is above 12, you can combine the yellow with the blue one, that is 12 plus 4. You can give 2 cartridges at the same go. So this is how you calculate the dosage, and you ask the patient to monitor the sugars 1 hour after the meal, and you can just follow as you are following up any of your basal bolus patients.
Okay.
At 3 months you repeat FEV1. That's a rule.
Thank you.
Thank you, ma'am.
So thank you everyone. Thank you so much, and thank you Nandita.
Wish you have safe journey back home.